Strength doesn't come from what you can do. It comes from overcoming the things that you once thought you couldn't. Good afternoon, ladies and gentlemen, and welcome to the International Webinar on Tobacco Control. My name is Nikita Menezes, and I'm going to be a moderator for this webinar. Every year on May 31st, the World Health Organization and its global partners observe World No Tobacco Day. This annual campaign is an opportunity to raise awareness on the harmful and deadly effects of tobacco use and also serves as a call to action, advocating for the effective policies to reduce tobacco consumption. In 2020, WHO revealed that tobacco consumption kills over 8 million people each year, and 1.2 million of those deaths were due to passive smoking, a number that only keeps on rising. This year, we at Manipal Academy of Higher Education have decided to join this fight against tobacco control by bringing together national and international experts to discuss the harmful effects of tobacco and the measures to control its use. This webinar is being organized by MAHE in association with the Medical Research Council of United Kingdom funded projects, Preventing Smoking Uptake and Tobacco Control Capacity Program, and also as a part of the Nasha Mukt Urpi Abhiyan project funded by the Ministry of Social Justice and Empowerment, Government of India. On this occasion, we are honored to have esteemed dignitaries and invited guests in attendance. I request Dr. Geeta Maya, the Director of Student Affairs at MAHE, and the Principal Investigator of the Nasha Mukt Urpi Abhiyan project to welcome our August gathering. Over to you, ma'am.
Good afternoon, ladies and gentlemen. It gives me immense pleasure to welcome you all to the International Webinar on Tobacco Control on the occasion of World No Tobacco Day 2021. This webinar has been organized as a part of Nasha Mukt Urpi Abhiyan under the auspices of the Nasha Mukt Bharat Abhiyan 2021. The Nasha Mukt Urpi Abhiyan, involving young leaders of MAHE, is a one-year project that is being carried out by the Department of Student Affairs, Manipal Academy of Higher Education, in collaboration with the Ministry of Social Justice and Empowerment, Government of India. The main objective of this Abhiyan are to prevent substance abuse, create awareness, and sensitize students of MAHE and also people living in villages in and around Udupi to the problems resulting from drug use. With regard to this Abhiyan, we have submitted a detailed proposal to the Ministry of Social Justice and Empowerment to achieve these objectives. One among them is to observe World No Tobacco Day. As we all know, consumption of tobacco is the root cause for venturing into more harmful illegal substances. This is the main reason for organizing today's webinar. It is jointly organized by MAHE in association with the Medical Research Council of United Kingdom funded projects, Preventing Smoking Uptake and Tobacco Control Capacity Program. At the outset, I extend a very warm welcome to Madam Radhika Chakravarti, Joint Secretary, Ministry of Social Justice and Empowerment, Government of India, for honoring our invitation to be the chief guest and for kindly consenting to deliver the inaugural address. Welcome, Madam. It's my proud privilege to welcome our esteemed Vice Chancellor, Lieutenant General Dr. M.D. Venkatesh, President of today's program, who has kindly consented to deliver the presidential address. Thank you, sir, for your wholehearted encouragement and support, and a very warm welcome to you, sir.
Thank you, ma'am. Thank you very much.
It's a privilege to have Professor Linda Ball, Bruce John Usher, Chair of Public Health, University of Edinburgh, as a keynote speaker for this webinar. Madam, I welcome you very warmly and thank you for having consented to deliver the keynote address. It's an honor to welcome the distinguished resource persons of the various sessions that are planned for today. Professor John Britton, Mr. S.M. Abdullah, Dr. Salam Abid, Dr. Aarti, Dr. Monica, Ms. Kellen, Dr. Muralidhar, and Dr. Samir, representing different acclaimed organizations and universities all over the world. At this juncture, I welcome the chairpersons of today's sessions, Dr. Veena Kamath, Dr. Asha Kamath, Dr. Suma Nair, and Dr. Ram Prasad VP, representing the academic fraternity of Mahi Manipal. Thank you all for accepting our invitation and a very hearty welcome to you, distinguished speakers and chairpersons. A cordial welcome to all the participants of this webinar. I hope you all will find it enlightening and fruitful. I also extend a cordial welcome to all Mahi officials, faculty members, student friends, and all other distinguished invitees attending this webinar. I thank all of you for joining us today.
Thank you, Dr. Maya. Thank you, Dr. Maya, for the warm welcome. Light is one of the most universal and fundamental symbols of knowledge. Just as a single lamp can light hundreds more, one knowledgeable person can share their knowledge with many more. It is our custom to begin every important event by lighting a lamp. I request our chief guest, Mrs. Radhika Chakravarti, to light the virtual lamp by clicking the play button. Thank you, madam. We are indeed very honored to have Mrs. Radhika Chakravarti, the Joint Secretary in the Ministry of Social Justice and Empowerment, Government of India, as our chief guest today. A graduate with a engineering degree in electronics and communication from Osmania University, Hyderabad, Mrs. Chakravarti looks after the Social Defense Bureau in the ministry and is responsible for implementing various programs relating to the social and economic empowerment of marginalized groups in India. One such program is the Nasha Mukt Bharat Abhiyan, which is aimed at eradicating drug abuse in India. Prior to this assignment, she had worked in the states of Assam, Andhra Pradesh, Tamil Nadu, and Telangana, implementing several prestigious government projects. She has been the recipient of several awards in her official capacity and was conferred the prestigious Director's Gold Medal by Lal Bahadur Shastri National Academy of Administration, Missouri, for being the best all-rounder trainee from all the civil services. With these brief words of introduction, I present before you Mrs. Radhika Chakravarti. Ma'am, I request you to please address the gathering.
Thank you so much. All the eminent speakers and experts, the faculty and the family of Mahi who are present here today, and especially my young viewers. This is one opportunity I would not have missed to be a part of this gathering. The circumstances have been very trying in the last few days or few months in our country. COVID has really created a havoc. It has hit almost everybody in the country. Perhaps there's no one who has not faced any difficulty or a bereavement in the family, which is a very sad state of affairs. And it is equally shocking to see that the most tough people have succumbed to COVID. And in this situation, when our country is picking up pieces and is coming back to its normalcy, to regain its strength, I would also like to draw your attention to one more serious problem, which is not as evident as COVID, but is definitely as dangerous and perhaps more, which is the tobacco and the substance addiction, which is prevalent in our country today. Before I joined as an officer, whenever I used to pass through, I used to feel that why is the government not doing anything about the beggars who are on the roads, of the substance users who are in this country, and the youth is falling prey? And I felt so much, perhaps that's why it's such a coincidence that I am working with this ministry and with these groups. Now, drawing back your attention, I will just state certain figures which are very, very important for our younger generation to know. Is what is the mortality rate in the country caused by tobacco? You would be surprised to know that every 8 seconds in India witnesses one death which is caused due to direct or indirect taking of tobacco. It kills more than 1 million people a year, mostly because of the cardiovascular diseases. And the current tobacco users in the India are 267 million, which is a very, very high figure. So if you look at the economic burden that the tobacco is causing our country is about 27.5 billion US dollars. If that is the kind of economic burden this addiction or this habit is causing to the country, should we not have a look at that from a different perspective? To the youth and the younger generation, a lot of people would have talked to you, your families would have talked to you, your peers would have talked to you, your faculty would have talked to you about why you should not, why you should keep away from tobacco or any kind of addiction. But I would like to give a different perspective. If it causes so much of economic drain, a drain of health, a drain of, mortality rate is so high, should you be a part of this? Should you not be thinking about this problem from a different perspective is one point which I would like to pose to the younger gathering which is with us today. If you look at substance, tobacco is always a gateway substance to harder drugs like cocaine, heroin. And it is an established fact. Very recently, about a week back, I had an interaction with the people who have fought this addiction of substances and who came out of that and now who are very well established within their own occupation or otherwise. They have a standing in society and they're working towards eradication of substance or tobacco addiction. My one question to them was, where did you start? How did it start? With what did it start? You'll be surprised that 100% of them said that we started with cigarettes. We started with smoking, and which they thought was a very heroic thing to do, was because of peer influence or because of certain factors of curiosity they started, not thinking that they would become an addict to that. I also have a very personal experience which I would like to share. It's a very personal experience, but I thought, my sharing that, if it causes even one of you to think about the whole thing, and then if one of you can actually carry this message forward that you should not be addicted to or you should not be taking the tobacco, then my purpose would be achieved. So this story goes like this. There is one person who's very close to me. Very, very intelligent, and in the Indian context, especially in the South Indian context, if you see doing maths, physics, chemistry and being a state topper, it's a very big thing. So this person is a state topper in his from school days and his 10th and 12th and all, and he passed out. He went into the IIT, one of the top institutions of the country, and has been doing very, very well. And now, having gone to IIT, then suddenly it's a newfound freedom. So so the person started using cigarettes, started smoking, and it started as a, when I asked the person, like, why did you start at all? Because it said, like, it looks good and I would feel like, very good about it. I thought, I looked good. And there's, of course, everybody around me is doing that, so that's how it is. So kind of acceptance, and that's how it started. And without, before the person could realize, it went into chain smoking, and he started doing about 40 cigarettes a day. And that continued, and he again passed out the IIT with again laurels. Good student that he, very good student that he was. But this habit continued. It continued to IIM Ahmedabad. The next step of the person was to go to IIM Ahmedabad, which is another premier institute. So this 40 cigarettes per day still continued. The person continued to like do well. Of course, his own capabilities are good and studies, everything was okay. So he thought it was working out wonderfully for him. So IIM Ahmedabad was over. The next step was to preparation for the civil services. He wanted to become an IAS officer. So right, the preparation started. And in the IAS officer, for the civil services, there are three stages, if you all know. One is the prelims, mains, and the interview. So prelims was crossed, mains crossed, very good. And then he was preparing for the interview. Now the interview will be followed by a medical examination. That's the process of the UPSC. So then that was the time when this person started coughing. And it was like, it was unbearable cough. So his mother, who was a surgeon herself, so she took the boy to for the test, and it so happened. It is just before, I think it was about a week before the interview, UPSC interview for any civil services aspirant. That is the day for them, the UPSC interview. So just 1 week before this interview, this boy was diagnosed with carcinoma. The report came that, the boy is diagnosed with carcinoma. Now, that was the point when that person, otherwise very, very, very stable, very intelligent, thought that the world was at his feet, collapsed there on the steps of the diagnostic center with his report in his hand. He went alone to collect that report. He was not anticipating what would be the content of the report. So he just thought, very playfully, he went to collect his report, and he collected the report, and he sat on the steps of the diagnostic center, thoroughly shattered, with a carcinoma report in his hand. So 1 week after that, he had attended the interview in the same very shattered kind of a frame of mind. He still did make it into the IAS. And then that was when it was decided that let him go through a different set of diagnostics again, get it rechecked and all that. And fortunately in his case, it was only the beginning of the thing. So it was like, it was curable. In fact, it was a very, very happy situation, and the person is fine now. The person is normal now, though there are other kind of complications which do come across later in his life, but the person is fine now. My question to the youth and to my young viewers here is that, for us to learn anything, for anybody to learn anything, it's not necessary that we should undergo a certain process. We should experience that good or bad thing. Sometimes it is important that we learn from the experiences of others. Now, this story which I shared with you, it's very, very personal to me. The person is very close to me. But it really causes a kind of stress at every point of time, to him, to me, to everybody. So this is the situation which should not, people should not face this situation. And that's the idea why I am here with you all to share this input. Now, coming back to tobacco, though it is not directly as a hardcore substance which affects the psyche of the person, but tobacco is definitely a gateway substance, and it definitely causes a lot of mental and physical distress leading to death. These are all proven aspects. So here I would like the youth who are present here, suppose say in Udupi district, the district where your education institute is located, the population is about 11.7 lakhs, out of which 25% are youth. Now, is it not your responsibility to reach out to these people, this 25% of the population of UDP, who are in about 1100 and odd schools and colleges, educational institutions? Is it not the responsibility? Is it not your responsibility? It is not our responsibility to reach out to them, to ensure and spread a message that please stay away. It's not worth being there. Please stay away. That is the simple message we need to convey. I would expect from the students of the Mahe to convey this. And if you look at the 6 point Karnataka, you come to Karnataka, the otherwise the better states, 6.1 crore people of the total population of approximately 22.8% are addicted to tobacco. 22.8% is a very, very, again, high figure. So if these are the statistics, if this is what the tobacco is doing to the youth of the country, and then coming to the environment for the future generations to stay happily and healthily, what is it causing to the environment? The cigarette butts they are the discarded piece of waste, and which are hazardous because they contain arsenic, lead, and other toxic chemicals which we are releasing into the environment, and subsequently it's a synergic cycle. It is coming back to us, which is just not worth it. So these are the experiences, which a lot of people approach the ministry, because this is nodal ministry. They approach with their stories, they approach for a lot of help. And that is where we started this Nasha Mukt Bharat Abhiyan. And I'm very happy that Mahe came forward and submitted a wonderful proposal, which we approved. And this Nasha Mukt Bharat Abhiyan, we are doing it in 272 most affected districts of the country. There are about 624 and above districts in the country, but we could not take up all of them at one go. The most affected 272 districts have been selected. And the main aim is that the district collectors of these districts are leading the program, and all the educational institutions in these districts are supposed to be a part of it. And then 272 districts are going to show us the way forward as to how to approach this problem, how to tackle this problem, and how to make our youth healthy and mentally stable and strong. With that aim, Mahe's proposal was approved, and I'm very glad that I am interacting with the students of Mahe, and the professors and the faculty have taken a lead in submission of this proposal and in carrying forward the various different kind of actions they have proposed in the proposal. And I just want one commitment from the students of the Mahe today during this course of interaction, is that let us have the strength, the mental strength, to say no to what is harmful to us. When we are aware that is harmful to us, harmful to self, harmful to family, harmful to the society, and harmful to our younger generations, people who are younger to you, then why do it at all? So let's not, smoke up our lives. And this is the commitment, I would expect from the younger students, the students of Mahe. And with this little message, I take your leave, and I extend my complete support and cooperation to the Mahe's administration in handling this issue. And to the younger generation, I would like to extend any kind of help. And my email ID is on the website. So anything which you would want, which the institution or as an individual you would want, because there are different kind of supporting mechanisms the ministry provides, we will be very happy to do that. And thank you for making me a part of this. Thank you very much.
Thank you, madam. It is indeed a privilege and an honor for us at Mahe to carry forward the Nasha Mukt Bharat Abhiyan here at Udbi. And I'm sure the personal experience that you have shared has touched the hearts of all those who are watching, and will give those who are struggling with addiction the much needed push towards making a positive change in their lives. Thank you very much for sharing your message. This truly is a very memorable event for us at Mahe, as well as our partners organizing this event. And we would like to capture this event with a photograph. I request all those who are present on the Zoom platform to please switch on your videos and pose for a photograph. Everyone present here, please click on your videos. Please switch on your videos. Okay. All the speakers, please switch on your videos. Okay, I'll be clicking the photo in 3, 2, 1. Just a minute. Clicking another picture in 3, 2, 1. Thank you so much. Today we are delighted to have Professor Linda Bold from the University of Edinburgh as a keynote speaker today. To introduce her, I would like to call Dr. Muralidhar Kulkarni from the Department of Community Medicine, Kasturba Medical College, Manipal, who has worked closely with Professor Bold in the Tobacco Control Capacity Program. Over to you, sir.
Very good morning and good afternoon to one and all. It's indeed a great pleasure and privilege for me to introduce Professor Linda Bold, the Bruce and John Usher Chair of Public Health, Usher Institute, College of Medicine, University of Edinburgh. Basically a behavioral scientist, but then she has combined her academic role with a secondment to cancer prevention at the Cancer Research UK as their cancer prevention advisor. She leads 2 research consortia, the Tobacco Control Capacity Program involving research teams in 5 countries in Africa and 3 in South Asia. Secondly, the Spectrum involving 10 UK universities and partner organizations, conducting research on commercial determinants of health. Currently, she is also an advisor to the COVID-19 Committee of the Scottish Parliament and a regular contributor to print and broadcast media on approaches to addressing the pandemic. Above all these academic credentials, as I see her, she's a wonderful human being, encouraging each and every one to do quality research, and also has been a great leader for the project and the program. Thank you so much, Professor Linda, for joining. Over to you for the keynote address.
Thank you very much, Murali, and I'm really delighted to be here. And I'll just share my screen. Thank you so much for the kind invitation. And also, I just wanted to thank the Joint Secretary for her very moving address a few moments ago. I'm just going to spend a very brief few minutes giving an overview on international tobacco control, and then you'll also be hearing from my colleague, Professor John Britton. Now, I think we all know the challenge, as we've heard from the Joint Secretary, that tobacco causes in India and around the globe. Between 7.7 and 8 million deaths, as we were hearing in the opening. And just to put that in context, all this is almost certainly an underestimate. So far, COVID-19 has resulted in 3.5 million deaths globally. So we need to align, as the Joint Secretary was saying, communicable and non-communicable disease responses. In tobacco control and at Manipal and with our partners and around the world, people often use the same approaches. And this diagram just shows you the main components of tobacco control. At the top of the slide, you can see the children, and most people globally who start using tobacco do that as children before the legal age of sale. And one of the key things we can do is reduce the appeal and supply of tobacco products to prevent uptake. Unfortunately, then, if people become tobacco users, a main focus for tobacco control is to support more quit attempts, so to encourage adults to stop smoking. And if they do so, we invest in research to try and provide them with the best interventions to facilitate that quit attempt. And that is laid out in a number of countries' tobacco control strategies. And then, of course, as we were hearing earlier as well, the threat of secondhand smoke from combustible tobacco products is significant. So we also have laws and policies to protect people from secondhand smoke. The World Health Organization has estimated that tobacco will cause 10 million deaths each year. By 2020, we haven't quite reached that, but it's projected still in a number of countries that we have more tobacco users. There's over 1 billion smokers worldwide, about 1/3 of the global adult population, and it's still the leading preventable cause of death in the world, and the only risk factor that affects all 4 of the main non-communicable diseases: cancer, heart disease, lung disease, and diabetes. And it's also an unequal burden, as I think you all know. It varies a lot between countries. Within the next few years, 80% of the world's tobacco-related deaths will occur in low and middle-income countries, and nearly half of men living in these countries smoke, but the gender gap is narrowing amongst younger smokers. And the 3 biggest countries I've listed here, in China alone, there's over 300 million smokers, which is equivalent to the whole population of the USA. And we know that India has a very substantial tobacco burden, not just from combustible tobacco, of course, but the many millions of smokeless tobacco users who are using products that are harmful to their health. This is a slide from the UK, but it just shows what can be achieved with comprehensive tobacco control, starting in the 1950s with important research showing the link between lung cancer and tobacco, and then gradually governments introducing a series of policies to try and denormalize tobacco use, banning advertising, raising taxes, media campaigns to prompt quitting, health warnings, billboards and print ads prohibited, smoke-free places, point-of-sale display bans, banning smoking in vehicles, and then standardized packaging of tobacco. And of course, many of these policies, but not all of them, you do have in place in India as well. The UK now has the second lowest rate of smoking in Europe, just behind Sweden. In the 1950s and 60s, we had the highest rates of tobacco use in the world. The research that you're doing at Manipal and partner organizations is contributing to the design of policies and interventions to reduce smoking. And of course, these effective policies and interventions are set out in the Framework Convention on Tobacco Control, which is the only global public health treaty. There's 181 countries, jurisdictions that are signatories to the treaty. And there are 38 articles within it that set out the kind of action that should be taken. I've just listed the key articles here. We'll probably hear more on this from Professor Britton in his recorded address. But many of these are active focus for research, and some we need more research on. For example, how do we harness the movement to address the climate crisis, the protection of the environment, Article 18, and how do we work on viable alternative economics activities? How do we tackle the illicit trade? These are urgent issues which for yet we don't have all the answers. So these are some of the things that we're focusing on in the Tobacco Control Capacity Program that Murali has already mentioned. And this is a wonderful joining together of 15 different organizations. And of course, Manipal Academy of Higher Education is a partner. We're working in 8 countries, and we are focusing on 3 main themes: supporting tobacco taxation, tackling illicit tobacco trade, and targeting tobacco company interference. We've also done work on youth prevention, smoke-free laws, and other themes within the program. And our aim is to improve research capacity to conduct high-quality studies that generate evidence on how to reduce the morbidity and mortality caused by tobacco use and advance key development priorities. So these are the things we've been doing over the past 3 years. We're in our final 6 months now, actually, of the program. And we've made fantastic progress. We have many dozens of publications and many more in train. And importantly, we've engaged with stakeholders. And Manipal has been a leader actually in that, in building stronger relationships with colleagues across state and other levels of government, working to tackle tobacco in Karnataka and beyond. And our research questions are around how does tobacco taxation align with international best practice? How can taxes be used? How can local capacity be harnessed to eliminate illicit trade? And what are the principal barriers experienced by governments in protecting public health policy from tobacco industry interference, which remains a substantial challenge? So thank you very much for listening. I did want to be brief because you have a very busy agenda. But just a personal note that it's been a privilege to work with colleagues in Manipal over the last 3.5 years, and just in particular to see the fantastic early career researchers, PhD students, research assistants, research fellows who've worked with us in the program. And we know they are future leaders, both in India and internationally. And I'm really have been honored to see them grow and flourish within TCCP and of course the other important programs that you have at Manipal. So thank you very much, and I'm looking forward to the rest of the webinar.
Thank you, ma'am. It is indeed our privilege to work alongside you on the TCCP program. Any project that we implement at MAHE has always had the unstinted support from our beloved Vice Chancellor, Lieutenant General Dr. M.D. Venkatesh. An ENT surgeon who has served 38 years in the armed forces, Lieutenant General Dr. M.D. Venkatesh has contributed significantly in the field of medical education, having published several papers and trained generations of undergraduate and postgraduate students in the Armed Forces Medical College, Pune. A recipient of numerous honors and awards, including the very prestigious Vishish Seva Medal by the President of India, Lieutenant General Dr. M.D. Venkatesh has held several prestigious positions in various institutes and organizations in the country. He has been a professor of otorhinolaryngology, served as a governor in the Board of Governors for the Indian Academy of Otorhinolaryngology and Head and Neck Surgery. He has been a member of the Medical Advisory Council for the newly commissioned National Medical Commission and has also been a member of the General Assembly of Indian Council for Cultural Relations, Government of India. Prior to joining MAHE, he was a Vice Chancellor of Sikkim Manipal University, and it was under his able leadership that SMU achieved the recognition as a leading private university in India. So we are truly delighted by your presence today. May I please request you to address the gathering?
Thank you. Thank you very much, Nikita. And good afternoon, everybody. And good morning in the western part of the world. It's been on this day when the entire world, rather gets into the mode of No Tobacco Day. It's very apt that the MAHE is organizing this program in association or in collaboration with the Medical Research Council, with the Tobacco Control Capacity Program, and the Ministry of Social Justice and Empowerment, Government of India. MAHE has always been an active participant in all such social activities, and MAHE especially has been participating in the tobacco control program with a lot of vigor and enthusiasm, and has shown significant success in these areas. At the outset, let me offer warm greetings to Ms. Radhika Chakravarti, Joint Secretary, Ministry of Social Justice and Empowerment, Government of India, to Professor Linda Baldby, whom we just heard her inspirational talk, and also to the other eminent resource persons and chairpersons and all the participants of this extremely important webinar, which is being organized on this day. As Madam Chakravarti clearly mentioned, in this day when the entire world is in the grips of this unprecedented COVID pandemic, when every thought and every action of most part of the world is directed towards it, it's extremely important that we also take a step back and look at other more important or equally important issues which trouble the mankind. And as the statistics have been clearly demonstrated and has been brought to the focus by both Ms. Chakravarti and Professor Linda Bald, as a practicing ENT surgeon and head and neck surgeon for over 4 decades, I've seen the devastation of use of tobacco, and especially in India, where more than 35% of the head and neck cancers is caused by tobacco use. And also, as very clearly brought out, the non-communicable disease part of the tobacco use is extremely depressing and extremely important that it is prevented. So as per World Health Organization, tobacco is the leading cause for preventable death, which has a mortality of over 8 million people every year. And as I mentioned earlier, it's in the field of cancer etiology which takes a center stage, and also the other non-communicable diseases. And tobacco is the gateway to the other addictions. Tobacco, along with alcohol and other substance abuses, is a devastating social problem, which most of the countries are facing, and more so in the middle and lower income countries. I just wish to highlight 2 points here today for us to ponder on. First, To what extent our youth is being affected by tobacco and other substance addiction, despite access to information related to their harmful effects? And second, as responsible mentors and institutions which are guardians of our society, are we doing enough to stop our youth from falling prey to this deadly vicious cycle? With a variety of smoking forms and an array of smokeless tobacco products, the tobacco issue is extremely complex. What is alarming is the growing number of youth that are indulging in tobacco use. These students certainly have better access to information, and most of them are aware of the side effects. And it is important for us to dwell upon what is driving them to these addictions then. It's time we deliberate on this issue, considering the multiple dimensions of the problem. Multiple dimensions being health being one issue, the social problems being the other issue, the economic burden being the other issue, and a global problem which needs effort from at a global level. So therefore, most countries have come into a collaborative mode and looking at how do we prevent the ill effects of tobacco, which then on leads to addiction to alcohol and to other substance abuse. The key factor that I wish to highlight is also about efforts made by people responsible to curb this man-made epidemic. It's important that we combine internationally accepted measures with regional and cultural specific plans with a focus on the impact of socio-cultural diversity. We need to look at measures that have proved effective in the developed countries while putting in a sustained efforts to develop alternate measures. The statistics provided by Dr. Linda Ball is an example that how UK has been able to bring down the ill effects of tobacco over the last, say, 70 years. It is in this context today that today's webinar is very relevant, and in this direction, the MAHE is organizing this webinar in association with Medical Research Council of United Kingdom, funded projects of preventing smoking uptake and tobacco control capacity program, and as a part of Nasha Mukta Udupi Abhiyan by involving young leaders of MAHE, funded by the Ministry of Social Justice and Empowerment, Government of India. At this juncture, I would like to assure the unstinted support of the MAHE administration towards making this endeavor highly successful. And all the participants, the workers, and the researchers who are involved in this program, I assure you of MAHE's fullest support to take this effort to the next level to reduce the burden of tobacco and its abuse in this district and in the country as a whole. We have experts in their respective fields in this webinar who would be in a better position to elaborate the need to create an awareness about the harmful effects of tobacco and the measures to be taken to contain its use worldwide. I'm certain that their deliberations would add to the existing body of knowledge. I take this opportunity to thank them for their dedication towards this noble cause. It's also important that as this addiction or this dependence begins at a very young age, it's important that our young leaders, that is our students, take this effort and educate and initiate the process of desisting from tobacco. Seen in all campuses that it is perhaps the most crucial time is the first year of admission to the higher education institutions. And I think aptly Dr. Geeta Maya is doing this project, and I'm sure as a head of the student affairs, she will take special efforts towards educating the newly admitted students of staying away from tobacco so that the burden of tobacco abuse reduces in the community. The youth are our future. Sensitizing and educating them against the use of tobacco and related use should be our first line of defense. This will not only make them feel part of the cause, but also ensure that the future generation do not face its harmful effects. Adding the substance abuse concerns and its repercussion as a module in the curriculum, conferences, student workshops is extremely vital. I hope these deliberations and such webinars will help us to create a better future for our youth. I take this opportunity to thank all the resource persons and delegates and my student friends who are present here today And I'm sure that this webinar will be of a great success and also will lead towards renewed efforts towards reducing the burden of tobacco and tobacco abuse in the campus, in the district, in the country, and in the world as a whole. Thank you very much. I extend my wholehearted cooperation and support in all these endeavors, and be rest assured that we stand behind you in this very, very noble and important cause. Thank you very much, and Jai Hind.
Thank you, sir. Your continued support and encouragement in all our activities is truly invaluable to us. With this, we conclude the formal part of the webinar. We now move on to the main part of today's webinar. We have 8 national and international experts from the medical field who will be sharing their expertise on the subject of tobacco use and its repercussions. Our resource persons will be happy to share any questions that you may have. So to all the participants viewing this webinar on YouTube, you may post your questions in the chat box. Without further ado, let us begin the first session. This first session is on tobacco control, the global perspective. To chair this session and introduce a speaker, we have Dr. Veena Kamath, a professor from the Department of Community Medicine at Kasturba Medical College, Manipal. Over to you, ma'am.
Thank you, Nikita. A very good afternoon and a very good morning to all present here. It's indeed my pleasure and my privilege to introduce Professor John to the audience. So Professor John, I think this is a very minuscule CV that is being projected here, but still it speaks volumes about his experience. So Professor John is currently the Professor Emeritus, University of Nottingham, and a former director of the UK Centre for Tobacco and Alcohol Studies, UK. He has occupied a number of leadership positions in the past, and he has been appointed as the Commander of the Order of British Empire for Services to Respiratory Medicine in January 2013. He was a former chair of the Royal College of Physicians Tobacco Advisory Group. He has been the chair for Public Health England Tobacco Control Implementation Board from 2014 to 19. His publication history speaks volume of his immense experience in research, with 250 original research papers in peer-reviewed journals and around 150 review articles, editorials, books, chapters. So as I told you, this is a very, very small CV. Besides all this, the value that adds to this CV is a wonderful person that he is, a very soft-spoken person. So I'm extremely glad to introduce Professor John. It's unfortunate that he has not been able to join us in the webinar in person, but still he has been kind enough to send his PowerPoint presentation with audio background. So over to Professor John. Let's see what he has to talk about tobacco control, the global perspectives.
Hi, my name is John Britton. I'm Emeritus Professor of Epidemiology at the University of Nottingham and a long-standing collaborator of Dr. Kulkarni and his colleagues in Manipal. And it's a great pleasure to me to be able to give this presentation in the webinar today. I just want to set the scene by saying how big a problem smoking is globally and moving on towards the challenge particularly faced by low and middle income countries. Tobacco kills. It kills over 8 million people a year and has been killing higher numbers of people every year for at least the last 30 years. These are preventable deaths. They are avoidable entirely by effective tobacco control policy. Smoking originated in Central America, was brought back to Europe by Christopher Columbus and other early Western explorers who ventured across the Atlantic to the New World. And then from Western Europe, it was transported to the many other countries in the world that the Europeans were trading with. And what we've learned over the years is that the tobacco epidemic in any one country follows a fairly set pattern, And it's laid out in this graph from Lopez and colleagues from over 25 years ago. They graded the tobacco epidemic into 4 stages. The first on the left, where men start to smoke, and the proportion of men smoking rises quite rapidly, but smoking among women is quite rare. After a couple of decades, male smoking takes off and may even reach a majority of men, while female smoking is still rising, but to lower levels. In stage 3, male smoking begins to decline and female smoking reaches its peak, but we are already starting to see deaths in men beginning to take off. And in stage 4, you have the peak of the epidemic of male deaths, still approaching a peak, or not yet at a peak, of deaths in women, but declining prevalence of smoking in both age groups. Now, most Western rich countries are at stage 4 of this process now, and some are even further along, where both female and male deaths, as well as smoking prevalence, are falling. But many countries around the world, and particularly the poorer countries in the world, are at early stages, and many indeed are at the very point of stage 1, where the epidemic could still be entirely aborted. And that's where global tobacco control measures have so much to offer global health. This graph or diagram shows the extent to which men in the world smoke. And you can see the darker the color, the higher the prevalence, with the darkest brown representing a prevalence over 40%. You can see that male smoking is commonest in Russia, China, and in Southeast Asia, and some other corners of the world. And in women, the pattern is very similar, but at a much lower level of prevalence. But now, with women being more likely to smoke in Russia, but also in Western Europe, but much less so around the rest of the world. If we look at the number of smokers, the overall numbers globally are falling. Among males, the peak was reached in about 2018 at just over 1 billion. In females, the numbers have been declining for some time, but these are total global numbers. They are not numbers, or these patterns are not representative of what's going on in poorer countries of the world. Here we have prevalence and number of smokers shown in low-income countries. The top graph of prevalence shows prevalence by age in men and women, with peak prevalence in middle adult life. And the bottom of the prevalence graph shows how prevalence among men has been declining steadily over the last 3 decades or so, and women more gently so. But the bottom 2 graphs show numbers of smokers. And of course, because of demographic change, many of the world's poorest countries now have a huge proportion of their population aged under 25. Now, among those young smokers, high smoking rates turn into very high numbers of smokers in the general population. So for men, we have steadily increasing smoking prevalence over the last, smoking numbers, sorry, over the last 30 years. And relatively steady figures in females. So what we have is a complete opposite picture in the different parts of the world. The rich countries, by and large, are past the worst of the tobacco epidemic. Poor countries are just setting off down the road towards developing the same epidemic of misery and death that the rich countries of the world have already endured. To counter the global epidemic, in 2003, the World Health Organization put forward the Framework Convention on Tobacco Control, a global health treaty, which came into force in February 2005 and is now legally binding in 181 WHO member states that have ratified the treaty. And this treaty seeks to protect present and future generations from the devastating health, social, environmental, and economic consequences of tobacco consumption and exposure to tobacco smoke. The convention contains a great deal of guidance on tobacco policy, but I've broken it down here into the main components of it, which are to raise prices through tax, prohibit advertising and other promotion, pay for health promotion campaigns to encourage people not to start or to quit, health warnings on packs, cessation services for existing smokers, protecting children by prohibiting sale to them, smoke-free public places, and measures to stop the influence of the industry on government policy. Now, there isn't time, or it isn't appropriate now, to go through all of those. But if we just look at the WHO's own figures for the extent to which these measures have been implemented, they're given along the graph here at the bottom. You can see them under what's called the MPOWER acronym. It's a way of categorizing these policies into a simple, easy to remember phrase. This shows the share of the world's population living in countries which are covered by policies in these categories: monitoring tobacco prevalence, smoke-free environments, cessation programs, pack warnings, mass media campaigns, advertising bans, and taxation. And the WHO are proud to say that nearly 2/3 of countries, comprising 63% of the world's population, now have at least one of these measures fully in place. But unfortunately, the other side of that coin is to acknowledge that 37% of the world's population in over 1/3 of countries have nothing. No measure fully implemented. The world has been sleeping through the tobacco epidemic over the last few decades, and with the current pressures of COVID, is likely to continue to do so. It is essential that we start to move to get these policies into place everywhere. One country that did so is Uruguay, which in the early 2000s adopted a comprehensive package of tobacco control policies based on the MPOWER principle. And the graph here from this study in the Lancet in 2012 shows how smoking prevalence fell in Uruguay, the green trace, compared with its neighbor Argentina, the light blue trace. Rates of smoking almost doubled relative to Argentina with the introduction of effective tobacco control policy. Now, this works to stop smoking in countries with established tobacco epidemics, but these approaches also work effectively to stop the uptake of smoking in the world's poorer countries that have yet to go down this route. And so I hope today we will learn a little bit more about what can be done, and particularly the measures that have been taken in India to promote a tobacco-free world. Thank you for your attention.
Thank you, Professor John, for that brief talk regarding the tobacco control from a point of view of global perspective. As he has told us very clearly about the burden of the tobacco use at the global level, as well as the strategies that are in place. The WHO had come up with the FCTC and what has been the impact of FCTC in some of the countries. I would request the audience to come up with the questions. We already have 2 questions from the audience. Professor Linda Bald will be taking over the questions that have been given by the audience. So Professor Linda, the first question is, at the global level, are there discussions on tobacco endgame, and what is your opinion on that?
Thank you very much. There certainly are discussions on the tobacco endgame, and there are a number of reports that have been published. I'd also draw delegates' attention to the consultation that New Zealand has launched. I think the closing date is today. And they have set out a series of ambitious policies that go beyond the FCTC to talk about an end game. So some of the new things that are perhaps not in place at the moment are things like a tobacco-free generation. So gradually saying that people born after a certain year cannot be sold tobacco. So that's an interesting idea in there. Another one is really reducing the availability of tobacco from many countries. So making the sale far less possible. Now, some countries have done that, for example, saying, well, you can't sell tobacco near a school, but you could have a levy on businesses or a registration system, which is in place in some countries, or licensing of outlets to try and reduce the availability. And so those are ambitious policies. And then the big one that has not been implemented, but I think needs to, is a levy on the tobacco industry. The idea of a polluter pays payment, which essentially would go beyond what some of the US states have done, where they've had a master settlement agreement and had revenue from the industry through court cases. Instead, you would be charging the tobacco industry for the fact that they're still producing cigarettes. So those are some ambitious endgame policies. We don't have a global endgame because, as John has said, so many countries are still to implement the Framework Convention on Tobacco Controls measures. But there are innovative ideas. And again, thinking about research, those are the kinds of ideas that we need to thoroughly research to support implementation.
Thank you, Professor Linda. The second question is, are there any strategies to enhance compliance of the parties to the FCTC guidelines?
So implementation is a really important priority. And what we see with the FCTC is each country or each signatory produces an implementation report for the FCTC Secretariat. And you can see if you look through those documents that not enforcing existing laws is one of the biggest barriers. And in fact, within the TCCP program, you can see, for example, our colleagues in Ethiopia have just written a paper around the fact that there is a ban on shisha houses in Addis and other places, but it's not enforced. So I think it is for national authorities to really take enforcement seriously. TCCP also produced a paper from Ghana showing that smoke-free laws were not adequately enforced, but were in place. So national and regional and district authorities really need to take responsibility for that. Thank you.
Thank you, Professor Linda. We'll just see whether we have any more questions. No, there are no more questions from the audience. Thank you, Professor Linda, and thank you, Professor John, for the wonderful presentation. Thank you. Over to Nikita.
Thank you, ma'am. Thank you for chairing the session. Thank you, Professor John Britton, for preparing the wonderful presentation. And thank you, Professor Linda, for answering all the queries. We had conducted an e-poster competition based on the theme Commit to Quit. This competition was open to all students, and we received an overwhelming response from the students all over India and abroad. Here are some of the posters. Those were some of the most amazing posters I've ever seen. Participants, if you did not see your poster, don't worry, because the remaining posters will be displayed after the second session. And the winners will also be announced then. So stay tuned. We'll now move on to the second session, which is on country-specific best practices for tobacco control. And we have experts from 5 countries to present the session: Bangladesh, Ethiopia, Ghana, India, and Uganda. The first 2 sessions on Bangladesh and Ethiopia will be chaired by Dr. Asha Kamath, Professor and Head, Department of Data Science, and the Associate Director of Prasanna School of Public Health, Manipal. Over to you, ma'am.
Thank you, Nikita. A very good morning and good afternoon to you all in your respective countries. It's a pleasure to be a part of this deliberation on the World No Tobacco Day. We have with us in this session 2 speakers. The first one is Mr. S.M. Abdullah, who is the Associate Professor from Department of Economics, University of Dhaka from Bangladesh. Is a honorary research fellow of the ARC Foundation and also a research fellow with the TCCP. Graduate in business and economics from the Lund University School of Economics and Management in Sweden. Has been actively involved in research activities of ARC Foundation since its inception, with a major interest in issues related to the field of health economics, international trade, and macroeconomics. Over to you, Abdullah, for your presentation.
Thank you. So I hope my window is visible to everyone.
Yes.
Yes, thank you, ma'am. So very good afternoon and good morning to you all, and warm welcome to the session. I would like to thank organizers for arranging such an important webinar and inviting me to present the scenario of Bangladesh in relation to tobacco control. This is S.M. Abdullah, TCCP Research Fellow working in ARC Foundation in Bangladesh, and I'm here to present the scenario of Bangladesh. I'd like to start by saying that every single death from tobacco is a preventable tragedy, and thus, across the countries around the world, several efforts have been taken to curb the prevalence of tobacco, such as banning the tobacco advertising, restricting public place smoking, help to quit, etc. All these are important for comprehensive tobacco control efforts, but they have limited effect because once they are in place, there is no further scope for prohibition. On the other hand, tobacco tax, which is excise in nature, are not subject to such prohibition and therefore considered as the most effective tobacco control measure. So let's have a look on the journey of Bangladesh in terms of controlling the tobacco. As you can see on the right hand side of my slide, I have prepared a time chart where I am presenting the journey of Bangladesh. If you look at the history, actually the tobacco controlling effort started back in 80s in Bangladesh, and specifically during 1988, Bangladesh government first introduced textual health warning on the tobacco packs, followed by in 1995, government banned the tobacco advertising, and followed by FCTC ratification in 2004. During 2007, National Tobacco Control Cell was established, and in 2015, government included tobacco control in national plan, like the 5-year plan for the country. Specific tobacco control law was enacted in 2005, and that was consecutively amended in 2013 and 2015. Particularly, this law specifies the practices for textual health warning, pictorial health warning, packaging rules, advertising, and public place smoke banning, selling to minor, use of misleading descriptors in the tobacco packs. Let's have a look how all these practices affected the tobacco uses in Bangladesh. We have used the data from Global Adult Tobacco Survey. There was 2 rounds of Global Adult Tobacco Survey in Bangladesh. One was in 2009 and the other one was in 2017. So as you can see, from overall perspective, the prevalence of smoking actually went down, and also in terms of gender and in terms of locality, the prevalence of smoking actually went down. But if you look at the absolute number of smoking population, still that absolute number is large. Around 37.8 million people still do this smoking in Bangladesh. So let's have a look, how costly the cigarette is in Bangladesh. As you can see, that nominal price of a cigarette in Bangladesh is going up, and during the period 2008 to 2018, the price of a cigarette actually increased by 5 times. But if we look at the inflation adjusted price and the nominal price, the difference between these two are actually going down. And if we compare the price of cigarette across some neighboring countries, we can see that the cigarette is one of the cheapest products in Bangladesh, and compared to other countries, other neighboring countries, still cigarettes are very, very cheap in Bangladesh. And another alarming thing is that in Bangladesh, the price dispersion among the different brands of cigarette is very, 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 very huge. So if you compare the premium brand cigarette and the most, sold cigarette, which is the cheapest one, the price gap is basically the 33%. And here, the higher the, percentage, the smaller the gap. And as we can see from the presentation, that in Bangladesh, the price gap is actually the, largest compared to the other countries. If we, look at the affordability of cigarette in Bangladesh, in terms of affordability now, Bangladeshi people needs to spend more percentage of their per capita income. But if we look at the per capita growth rate of Bangladesh, that per capita growth rate has been phenomenal, and Bangladesh has been growing in a fascinating rate in terms of their per capita income over the last last 1 decade. And this phenomenal increase in income of increase in per capita income of Bangladeshi people actually to some extent affected the affordability level of a cigarette in Bangladesh. And obviously, in such circumstances, tax is an important issue which can increase the price of cigarette and help us to reduce the prevalence. If we look at the tax in our country, we can see that during 2018 and 2019, in this particular fiscal year, the total tax incidence in cigarette price in Bangladesh, it was 71%, which is also kind of one of the highest for the countries compared one of the highest for countries compared to the compared to the other Southeast Asian region. So the question arises, if the tax incidence is such high, and if affordability at the same time is also going up, so why actually in our country the prevalence is not going down at a faster rate, and still we have such a huge number of population who is going for the smoking and going for using the cigarette and other tobacco related products. So there must have been some issues related with the tax structure design in our country, as well as there must be some issues related with the tax administration. So what needs to be kept in mind is that tobacco tax design should have twin policy goal. One is public health, which is the reduction of prevalence, and the other one is revenue goal, which is the increase in tax revenue. So in such circumstances, let's have a look what kind of tax structure Bangladesh is practicing. As you can see, this is the latest tax structure that Bangladesh is practicing. And as you can see from the slide, that in our premium, high and medium price tier, the total tax incidence is around 81%. And we have health development surcharge, as well as we have supplementary duty, and most importantly, the excise tax, which has been implemented in Bangladesh, is ad valorem in nature, and we have different tiers for the cigarette market. So the main problem with the current tax structure is that the tax structure is tier based. Ad valorem excise tax is in practice, and the low base price of cigarettes and bidis, and there is substantial variation of the taxes in taxes for the different types of tobacco products. In terms of tobacco tax administration, if we have a look on Bangladesh and other Southeast Asian region countries, we can see that only in Bangladesh we have ad valorem excise tax in practice, but in other countries like Indonesia, Myanmar, Nepal, Sri Lanka, they have a specific excise tax, and in India we have mixed excise tax. In marketing scenario, in Bangladesh we have 10 and 20 stick cigarette packs. Bidi comes at 8, 10, 12 stick cigarette pack. Bidi is a locally made cheap cigarette. And most importantly, all retailers can, single stick sale, and this loose sale actually is hindering to some extent our tobacco prevalence as well. And we have different smokeless tobacco products in place in the market. And in terms of tobacco tax policy, roughly 10% of the total tax, total revenue received by NBR comes from tobacco tax. But unfortunately, we do not have any written tobacco tax policy in place, and it usually changes annually. The rate usually changes annually. So as per the WHO recommendation, WHO always says that you need to have a simple tax system for tobacco, and it should be equal for all tobacco products, and regular increase in taxes should be there so that the price increases by at least 12% over inflation every year to stop the tobacco. So what are the major problems that we can identify from here for Bangladesh? We have a multi-tiered and complex tax system with low base, flaws in a tax tier design, which creates huge price differential among segments, no unique identifier mechanism, and hence no effective tracking and tracing system. Government concepts a part of only from yearly upward price adjustment because of this ad valorem system in tax, and base price for bidi and smokeless tobacco is extremely low, and challenges for proper tax administration is already there. So from our perspective, the researchers have 4 specific recommendations that we need to do to achieve the public health goal of prevalence reduction, as well as fiscal goal of increasing the tax revenue. Is that we need to have a comprehensive tobacco tax policy. This is high time that we need to have a comprehensive tobacco tax policy, which will address the illicit trade feature, which will address the tracking and tracing, which will address the packaging, which will address the advertising, which will address the tobacco as a holistic manner. So this comprehensive tobacco tax policy should be in place. And we would like to recommend that in place of ad valorem, we want to implement uniform specific tax. The benefit of uniform specific tax is going to be that it's easier to administer, and as well as there will be less scope for the industry, to do some manipulation in the market, and also it would be easier to predict the predict the tax earning by implementing the uniform specific tax. And also we need to simplify the structure. We don't want to have 4 different tiers. Rather than if it's possible, there should be no tier, and the tax rate should be progressive in nature. And obviously we also want to have some unique identifier and tracking and tracing system for the tax instrument that currently Bangladesh is being implemented. So obviously in term as far as tobacco tax is concerned, the tobacco tax structure is concerned, the simpler the better. Tax them equally, they all have the worst public health impact. So I would just like to conclude by saying by mentioning one quotation of father of economics, Adam Smith. And as we all the researchers wants to stand on the shoulder of giants. So back in 1776, Adam Smith mentioned that sugar, rum, and tobacco are commodities which are nowhere in necessities, and they should be taxed. So we have this age-old justification, and we have this age-old rationality that tobacco products are nowhere in necessities, and they should be taxed in every manner. I believe that if we can make our policymakers across the countries in the world listen to the researchers, in that case we will be successful to control the tobacco prevalence, and we will be successful to achieve our public health goals. I will stop here. Thanks for giving me the opportunity, and happy to answer any query. Thank you. Over to you, ma'am.
Thank you, Abdullah. We'll have the questions after the next speaker, so please hold on and hang on for your questions. I'd like to take this opportunity to invite the next speaker of this session, Dr. Selam with Hirpa, a research fellow of Addis Ababa University, Ethiopia, with 8 years of experience as a faculty member at the Adama University. She has been engaged in a cancer research project at Addis Ababa University for 2 years, and a research focus on tropical medicine and infectious disease, tuberculosis, and reproductive organs cancer. Over to you, Dr. Selam. Welcome, and over to you.
Good morning and good afternoon, everyone. I'm Salamai Tirpa from Addis Ababa University School of Public Health. So today I will present on Ethiopian best practice for tobacco control. I'll start from the background. So Ethiopia is the second most populous country in Africa with a projected total population size over 105 million in year of 2022. This is based on the Central Statistical Agency projection. And Ethiopia has 10 regional states and 2 administrative cities. That's including the capital city, which is Addis Ababa. So when we come to the tobacco, Ethiopia, the overall current tobacco use prevalence is 5%. This is based on the Global Adult Tobacco Survey, which was only conducted in year of 2016. The other important thing is JTI became the major shareholder of the tobacco industry. This was done in year of 2016 and 2017. So for many years, it was state-owned, or it was a monopoly or owned by the government. But in year of 2016 and 2017, Japan Tobacco International became the major shareholder. The other interesting fact is Ethiopia represents a huge opportunity for the tobacco industry, that's to recruit new smokers. This is because as a country, it's a large population, and also the majority of the population is a young population. Also, the tobacco industry themselves said that Ethiopia is a good place also to expand their market in Africa. The other important thing is Ethiopia is one of the countries who signed the WHO FCTC early in 2004, so which was encouraging. So when we become to the point where what were the best practices and what are the best practices for tobacco control in Ethiopia, so I'll start from year of 2009. So in 2009, there was a proclamation, and that proclamation gave the FMHK the authority to regulate the content manufactured, import, export, and distribution, sale and use, packaging and labeling, and disposal of tobacco products for FDA. So before this year, the National Tobacco Enterprise itself was the one who controls everything, distributes, and also has an authority to the import and export. So in year of 2012, also advertisement and promotion of cigarettes or other tobacco was prohibited from any kind of national media programs like TV and also radio programs. That was also one important thing. Also, there was another regulation in year of 2013. In that era, it was given that FMHK was given a full mandate to place licensing requirement on sellers and prohibit the sale of tobacco products to minors, that's less than 18 years, and also require text or picture warning on pack, and also to restrict smoking in certain indoor places. So also in year of 2009, FMHK was given an authority, but the difference was in this 2013 regulation, more attention was given for the public. So that was one improvement. In year of 2014, it was a big step forward for Ethiopia because Ethiopia has ratified the WHO FCTC. So even if it took like almost 11 years after signing the convention, but it was also an important point. And FMHK, or the current Food and Drug Administration Control, was given an authority to control tobacco. In year of 2015, another important thing in tobacco control is FDA issued the first comprehensive national tobacco control directive. Especially previously, before the year of 2015, we can say as a country, attention was not given generally for non-communicable disease. This may be related with different factors because Ethiopia is also one of the countries with high burden of communicable disease, and most attention was given for communicable disease. But in year of 2015, attention was given in general for communicable disease, NCDs, and also one of the things also was on tobacco control, and National Tobacco Control Directive was issued by FDA. So this National Tobacco Control Directive has many gaps. For example, it doesn't include WHO Article 5.3 recommendations, which are very important guideline, but also important legislation pointers. For example, sale of flavored tobacco products was prohibited, which is including shisha, and direct and indirect sale of tobacco products to person under the age of 18 years also was prohibited. And also nominally ban of all form of tobacco advertising, promotion, and sponsorship was banned. The other very important thing in year of 2015 is National Tobacco Control Coordinating Committee was established, and FDA was the lead organization. So this National Tobacco Control Directive have 23 members that are from the health department and also non-health department. From health department, that includes Ministry of Health, FDA itself, and research institutions like EPHA, and different non-health departments like Ministry of Trade, Ministry of Finance, Custom, Revenue. So this is a very important step so that to communicate each sector. And this National Tobacco Control Committee prepared the first draft of National Control Strategic Plan, that is from the year of 2017 to 2020. The other thing is tobacco focal person was in place at Ministry of Health and FDA. So this is also the first big step for the country. Another thing is on the tax system. So Ethiopia has introduced a mixed excise system on cigarettes. So previously it was a development tax structure on cigarettes. And this involves the current mixed excise tax system involves 30% tax rate of the cost of producing cigarettes, and in addition to a specific excise rate of 8 Ethiopian per packet. The packet means 20 cigarettes. So even if this is not as what is recommended by WHO, but it's still one step forward as a country. The other one is Food and Medicine Proclamation. So this is a very strong law for tobacco. So Ethiopia even has been recognized as a country for producing this tobacco control law, recognized by WHO. And this includes many important articles, which is similar to the WHO FCC. So some of these are 100% smoke-free public and work places, ban of tobacco advertising and promotion, restrict the sale of tobacco products. So in Ethiopia, selling and even smoking shisha is prohibited, but it may not be fully implemented. I can say that there is a gap in the law enforcement. Also mandate pictorial warning label covering of 70% of the front and back of all tobacco products. So this has been already implemented. This proclamation was in year of 2019. So after that, this was implemented, or so this is also very encouraging. The other one is ban of the sale of heated tobacco product, e-cigarette and shisha, and prohibit tobacco sale to under the age of 21, and included most of the recommended guideline of WHO FCC Article 5.3. So especially in the National Tobacco Control Guideline, which was introduced in year of 2015, there were a lot of gaps, but this one is more strong tobacco control law. So I can say that Ethiopia has a strong tobacco control law, but we have a lot of gaps in the implementation, and we have to work on that. Thank you so much for listening. So these are the references that I used. Thank you so much for listening.
Thank you, Dr. Elamita. It was a very crisp presentation about the taxation on tobacco products, in an effort to control tobacco use. There are a couple of questions for both the speakers. Let me begin with you only. So I just saw a mention of the size of the your health warnings to about 70%. So is there any scope for introducing, size, increasing the size of this health warning to more than 80 or 85% as recommended in the FCTC?
Okay, so previously it was only, even there was no graphic warning on the tobacco packets. So this has been implemented before a year, but currently there's no intention to increase to 85%. So there's no intention for increasing to 85%. It's only 70%, but it has also graphic health warning.
And then Ethiopia is having, say, 10 regional states and 2 administrative cities. So is there any geographical difference with regard to the taxation on tobacco products?
No, there's no geographical. It's true that Ethiopia has 10 regional states and 2 administrative cities, but it is similar in all regions. So there is no difference based on the region.
So do you have a significant difference based on the brand or the type of the product on the taxation?
The current one is mixed system, and it's based on 30% from production cost plus 8 on each packet. So from based on my knowledge, or as there's no difference on that. But so the most commonly used cigarette is Niala, which is a very cheap, which is used more than 90% of the smokers. But there are very expensive brands. So the tax system, as to my knowledge, there is no difference.
Thank you. Thank you very much for being a part of this deliberation.
Thank you so much.
May I invite Mr. Abdullah now to take the questions addressed to you. You know, you have given a very good glimpse of the change in the tax system on tobacco products. Now, after the introduction of the new policy that has been introduced on taxation on tobacco, has the tobacco industry brought out any low-priced products?
Yeah, thank you, ma'am. Very good and very pertinent questions. As Bangladesh has been, changing these taxes on an ad hoc basis every year. So, as I have mentioned in my presentation, that we have 4 different tiers of cigarettes: premium, high, medium, and low. So when there was a change in cigarette price because of changes in taxation back in fiscal year 2018, we have seen that tobacco industry actually tried to take out some of the brands from a particular tier and try to infuse new brands in the other tier, especially focusing on low and medium. So this practice actually took place in earlier years in Bangladesh. But as I have mentioned in my presentation, that we need a comprehensive tobacco tax policy. So we need to design the policy in such a way so that these practices can be curtailed.
So there is the rise in taxation always puts the industry to do a lot more research than us who are working in the tobacco control activities. So do you think that industry is coming up with tactics in playing a role in the sale of single sticks?
Yeah, this is another interesting question and interesting part to focus on. And personally, as a tobacco control researcher, I believe that still having this excess of loose stick selling actually hindering our tobacco control effort a lot. So yeah, there might we have seen a lot of tactics from tobacco industries earlier, especially focusing on influencing the tobacco tax policies, and also when we were trying to introduce the policy for pictorial health warning and textual health warning. We have seen that they have there was some kind of dynamics from that part. It might take place, but of course, as I said, that government should always be aware about these tactics, and if if public health goal is given the priority, in that case, of course, this type of tactics should be always minimized, and this should be overlooked. So I think it's all about, as I said in the last slide of my presentation, that it's all about the convincing the policymakers. So if we can convince the policymakers with our evidences, then of course I think we will be able to make tobacco control policies free from all kind of tactics from the tobacco industries.
One last question. Has race on the tobacco tax in Bangladesh given a scope for illicit trade?
Yeah, thank you, ma'am, for asking this question. Yeah, actually, illicit trade is my one research area, and from a broader perspective, I would like to divide illicit trade in two different topics. We can consider illicit if it's a smuggled product, and we can consider it illicit if it's a kind of counterfeit product. So if you look at the cigarette market in Bangladesh, I believe that the foreign cigarettes are very, very, very low in terms of they have a very low market share, and the illicit activities which is actually present in our country, the rate of that illicit share of the market would be very low, and mostly the practices will be related to the local malpractices focusing on the tobacco control laws. For example, are they following the compliance for packaging? Do they have authentic tax stamp, which is the instrument government usually used to collect the tax from the cigarette packs? So obviously, as a researcher, I would like to consider the illicit trade as a governance issue rather than an issue related with the increasing tax. Actually, to be honest, this is an age-old myth that tobacco industry will use, that if you increase the tax, then it's going to it's going to push the illicit trade. But of course, illicit trade is something which is very much related with the governance. So if we can monitor the tobacco market properly, if we can have a very effective tracking and tracing system, in that case, of course, this illicit trade can be curtailed. And obviously, I would like to mention here that in Bangladesh, the size of that market is not that very big, and we don't need to really worry about that, and we can go for making the comprehensive tobacco tax policy focusing on changes in tobacco tax.
Thank you very much for that nice pathway of the taxation role on the control measures in Bangladesh. I would like to thank both the speakers of this session, and I also thank the organizers for giving me this opportunity to be a chair for this session. Thank you.
Thank you. Thank you.
Over to you, Nikita.
Thank you, ma'am. Thank you so much for chairing the session. And I thank both the speakers for presenting, for such a wonderful presentation and answering all the questions. Thank you. The second session on the best practices for tobacco control will be in Ghana, India, and Uganda. And this will be chaired by Dr. Suma Nair, Professor and Head of the Department of Community Medicine at Kasturba Medical College, Manipal. Over to you, ma'am.
Thank you, Nikita, and happy to be here. Hello to everyone, and especially the three speakers who are in this panel, who have some interesting experience that they're going to share with us. So first up, I would like to request Dr. Aarti Singh, who's a public health physician and a senior lecturer at the School of Public Health at the KNUST at Ghana. She's been working in tobacco control research in Ghana on smoke-free policy and illicit tobacco trade. And her research focus expands across qualitative research, non-communicable diseases, and community engagement. Over to you, Dr. Aarti. We would be very happy to hear your experience.
Yes, please. Thank you. Good afternoon to everyone in India, and good morning to our colleagues in the UK and other parts of the world. So I am Aarti Singh. I'm based in Ghana, and my presentation is on some of the best practices that has been happening in Ghana for the past few years. I'd like to share my slides. Let me see if yes. I wonder if it's coming on full screen, but that's the best that's coming right now.
I think you can put it on. Yeah, that's fine.
That's fine. Yeah. Okay. Yeah. So in short, I think, okay, so let me just give a brief introduction of where Ghana is. So Ghana is the low and middle income country in West Africa, and it has a population of about 30 million. And I would say in terms of tobacco control, things have been fairly good. In the sense that Ghana was one of the first countries to become a party to the WHO Framework Convention for Tobacco Control. And it was about the fifth country in Africa to really ratify the framework for tobacco control. And then it went ahead to pass down a Public Health Act somewhere in 2012. That was really also after so much of efforts by policymakers and civil society organizations, there was actually finally a Tobacco Control Act that came out into the system. Then Ghana went ahead to pass tobacco control regulations in 2017 that really had more focus on introduction of pictorial health warnings and then smoke-free policies in Ghana. And then in 2019, Ghana went ahead to ratify the illicit tobacco protocol, but the finalization of this protocol has been delayed to some extent because of COVID that came into the picture. So if you open the UN site where we have countries that have ratified the illicit tobacco protocol, you might not see Ghana's name because that process is still pending, and that has all been delayed due to COVID. So I think that's the last stage that's left, but Ghana has completed all its formalities in terms of ratification of the protocol. And then interestingly, well, that's quite interesting that we don't have a tobacco industry. We used to have one as at up to about 2006, after which the tobacco industry, the BAT, a British American Tobacco Company, moved to Nigeria. So in Ghana, we don't have an active tobacco industry participation. But we do have a national interagency committee for tobacco control, of which I'm also a member of. And then we have these tobacco control strategic meetings almost every quarter of the year. And when it comes to the tobacco use in Ghana, Ghana has been lucky in terms of the fact that we've had the prevalence of tobacco use most of the time below 10%. And the recent demographic health survey in 2014 indicated that the prevalence was actually reducing a bit more further than what it was in the previous survey. So currently it's about 4.8% in males and about 0.1% in females. It has always been in that for like that way, that males have always been more of the smokers in Ghana than females, and the females constitute a very, very few of that percentage. When it comes to tobacco use among young people, so the GYTS that was conducted sometime, the last one in 2017, indicates that about 8.9% of boys and about 8.2% girls are currently using some form of tobacco. So it is becoming a problem among the young people as compared to the older people, the DHS, which really uses the population from 15 years to about 49 years. But the young people that the GYTS was concentrating on was about 13 to 15 years, and that's what we found. And if you can see the small table that I have in my presentation, you can see that the tobacco prevalence has actually been coming down all the way from 2003 to 2014. And the same pattern has been followed somewhere in the GYTS also, although in 2009, there was a slight of a spike. And in 2017, the numbers have dropped again. So, but the interesting thing that really is in Ghana is that most of it is not socially and culturally acceptable. So it might be possible that these numbers might not really reflect the very true picture of what's happening in terms of tobacco use, because most of it is done because it's more of a stigmatized practice in the country. It's probably not done openly, but within, from the research that we've been doing with the TCCP program in Ghana, we realize that there is some sort of tobacco use that goes on that we really are not able to measure with some of these surveys that happen. An interesting area that Ghana has made quite some good progress is in the smoke-free policy. So we have a partial smoke-free policy that allows the use of designated smoking areas, and then it has no smoking signs at various areas in the public places. And Ghana is following the partial smoke-free policy. And although WHO recommends that countries should go in for a comprehensive smoke-free policy that does not allow any smoking in any public place, Ghana is still following the partial smoke-free policy. But the interesting thing about this policy in Ghana is that as part of the TCCP program, we did some measurements of air quality in Ghana. And we realized that the air quality in some of these hospitality industries in Ghana, like hotels and pubs, in 3 cities that we went ahead to do this study in, realized that the air quality was getting quite very impressive in terms of the quality was very good as compared to what was noticed sometime in 2007. So the WHO air quality level for like optimal average air quality level is about 25 micrograms per meter cube. And currently is about 14 micrograms per meter cube, which is quite impressive. And it was about over 400 sometime in 2007. So we could attribute all this to maybe low smoking prevalence that is really ongoing at hospitality venues, and people don't want to be seen smoking, so we don't have a bigger problem of secondhand smoke. Or it could also be that maybe the cities that we went in to do the study were not really representative of the air quality monitoring that we wanted to do. So although there's still a long way to go in terms of compliance with smoke-free policies, and then we need a bit more of compliance, because some of the venues that we visited, we realized that smoke-free policies were quite not being followed up. And then we did not see a lot of places where they had no smoking signs. And although this was allowed, we still noticed that the air quality was fairly better than what was there about a few years back. And we want to recommend to the policymakers in Ghana that we should still go in for a comprehensive smoke-free policy that just does not allow smoking in public places, sort of completely banning smoking in public places. When it comes to tobacco packaging and labeling, I would say Ghana is in a much better position, because it's in Africa in total, just about 10 countries have actually implemented packaging and labeling in the form of pictorial health warnings. And Ghana is one of those 10 countries that has really implemented pictorial health warning labels. And currently our warning labels are in the form of 50% in the front and 60% at the back. And there's also the ban of use of terms like light, ultra light, or low tar on the packs. And even for smokeless tobacco packs, the policy recommends that we should have that on 60%, 65% of the front and the back of those packs. And here you can see some of the examples of these warning labels that we have. These are made specifically for Ghana, that was adapted. And but one of the drawbacks right now that we're having is that shisha, which is actually increasing in among the youth in Ghana, we still do not see like proper packaging and labeling on shisha packs. So that is one challenge that we've noticed with tobacco packaging and labeling. Although when it comes to cigarettes, Ghana seems to be doing quite well in terms of packaging. Sales restrictions in Ghana are also prohibition of sales of tobacco products. So you cannot buy cigarettes via vending machines. We don't have that that in place, or through the internet, or maybe in educational facilities or stadiums. We have prohibition of sales of these tobacco products in some of these open areas. And although there's a ban on the sale of single sticks, our recent study on illicit tobacco trade in Ghana did reveal that single sticks is sort of an ongoing problem. So the ban on single sticks is not the best in Ghana. And I think with our future studies that we will be doing, we would have to look critically at the sale of single sticks in Ghana. And the sale of tobacco products when it comes to persons under the age of 18 years is quite strictly prohibited. So that's not that has also been fairly followed up by the vendors of tobacco products. Tobacco advertising, promotion, and sponsorship in Ghana is also prohibited, and you're not allowed to advertise and promote your products. And this has been, Ghana was one of the first countries in Africa to sort of bring about an advertising ban somewhere in 1982, even before the Framework Convention of Tobacco Control was passed. So when it comes to advertising, Ghana has been quite, it's done quite well in that area. And some studies that were conducted in about 3 to 4 cities by some civil society organizations, they revealed that even advertising on the media was quite less. Use of billboards or even promotion activities by industry was not something that was being done within the past decade. It's all come down. And yes, so like I said earlier, that we don't have an active tobacco industry. And much of the evidence around what the industry is doing or what they're doing behind the scenes with government officials or maybe with other organizations to push their product, I would say the drawback here is that we don't have much evidence, but what we can clearly see is that there doesn't seem to be a lot of corporate social responsibility by these tobacco industries. And this it's not quite obvious, so we can't really make a case for tobacco industry interference. What's looking like is that the industry is not doing much of its sort of, even though Africa looks like a huge market when it comes to the tobacco market, as tobacco consumption is getting lower in high income countries, most of the industry and tobacco industries are like sort of moving into countries in Africa and some parts of Asia. And there's not much evidence to make that conclusion that the industry is really interfering, although we have like sort of anecdotal evidence that suggests that sometimes the industry manipulates our taxes and the sale of products, or sometimes goes behind the scenes to sponsor some events. But these are not really, the evidence behind them is not very clear. So we can't really make a case for the interference of the industry. And I would say Ghana is one of the few countries in Africa that has a smoking cessation national guideline, and which is really in line with our World No Tobacco Day, our theme for this year's Tobacco Day, no Tobacco Day that we have for this year, for 2021. And in 2007, there was a draft manual on cessation that was developed, but it took almost about 10 years for this guideline to come into place. So currently we have a national cessation guideline, which I think is present in just about 10 countries in Africa. So Ghana is really in a good state when it comes to cessation guidelines. Although we don't have much details on how much of these guidelines are being followed up, but yes, just to have a national cessation guideline tells you that the government really takes tobacco issues at least seriously and wants to do anything to prevent the youth from getting into sort of habitual smoking and other habits. And we do have some smoking cessation counseling that happens at some of these primary healthcare centers. And we do have also a hotline or a quit line that is there. But the use of these quit lines is what we're not very sure of how much they've been useful, because we've not really had much research done around that area. So to conclude, I would just go ahead to say that, yes, Ghana, I would say Ghana is in a better position when it comes to tobacco control, and we can do a lot if we really want to halt the tobacco epidemic in Ghana at this very early stage. And we are over 10 years after the WHO FCTC implementation, so that really tells us that we've gone far in terms of tobacco control. But the implementation of some of these policies when it comes to smoke-free policies or maybe industry interference, we don't have a lot of data to support some of these policies to be able to make robust changes to what can be done. That's what the Tobacco Control Capacity Program has been able to do with some of the researchers that they've been able to work with. And in Ghana, we've been able to demonstrate some evidence when it comes to smoke-free policy. And our current work on illicit tobacco trade is also showing some very interesting results. So I would just say that the TCCP program has been very instrumental in opening our eyes when it comes to the tobacco control, the problems related to tobacco control in countries like Ghana, where tobacco research has been sort of neglected. And I thank you all for giving me the platform to speak about the story of Ghana. Thank you.
Thank you, Dr. Aarti. That was a very interesting take on the work that's being done in Ghana. We'll take the questions towards the end of all the three talks. Yeah. Over to our next speaker, who will be talking about the tobacco control initiatives in India. We have with us Dr. Monica Arora, the dynamic Deputy Director of Hriday, the non-profit organization that works on health promotion, health advocacy, especially among the youth. She's also a public health scientist working in the area of preventing and managing non-communicable diseases, and is a professor at the Public Health Foundation of India and the president-elect of NCD Alliance. She has several awards to her credit, and in particularly, she was honored with the Best Practices Award in Global Health by the prestigious Global Health Council for demonstrating best practice in the area of preventing NCDs, particularly among the youth. And in 2012, she was awarded with the WHO Director General's World No Tobacco Day Award. Over to you, Dr. Monica, and we look forward to hearing from you.
Thank you so much, Dr. Nair. It's a pleasure to be speaking with all of you. I would just share my screen and wishing everyone a very happy World No Tobacco Day. I wish this is a day we see every day as important for tobacco control. Talking about best practices related to tobacco control in India, I will be talking about what we have done under TCCP, but otherwise as well in India, just to provide an overall framework of tobacco control. Just to mention, it's an absolute pleasure to be a part of TCCP. It's a family which we all have built together, and special thanks to Linda for leading this in India and in other countries. And it's absolutely wonderful to see so much work which has come along because of this grant, and so many countries are working together on tobacco control. So tobacco burden in India is unique because of both smoking and smokeless forms of tobacco use. And we are among the highest consumers as well as the producers in tobacco. More than 1.2 million deaths in 2019 were attributed to the use of tobacco. And we have current smokers about 55.4%, and 49.6% as smokeless tobacco users. Also, 19% of men and 2% of women among adults, which are 15 and above, are currently smoking tobacco. And the total economic cost attributable to tobacco use from all the countries has recently been looked at, and it is a whooping, in Indian rupees, it is 177.3.4 billion. And in US dollars, this works out to be 27.5 billion US dollars. So tobacco is the single most preventable cause of death and disease in India as well as globally. Moving further on, I will quickly talk about why we are saying that there are best practices in India, because India has been dealing both with smoking and smokeless tobacco products very, very effectively, and understanding that tobacco control interventions require contextualization. With COVID and tobacco, very early on, our Indian Council of Medical Research did come up with policies around how to prevent further transmission of COVID and smokeless tobacco, because requires frequent spitting. So there was this ICMR appeal to the community to refrain from consuming smokeless tobacco products and spitting in public places. And in line with this, Ministry of Health, Government of India did issue advisory to the states to raise awareness on this issue. And this was a very opportune time to be able to motivate people to quit as well, knowing the close association between those who were tobacco users, and if they were hospitalized, the outcomes were much more severe for them if they were hospitalized for COVID. In terms of smokeless tobacco, since our consumption for smokeless tobacco is much higher as compared to smoking, India did start taking its steps towards tobacco endgame, because way back in 2012, we did announce a prohibition on smokeless tobacco ban, and this started particularly with a gutka ban. So from 2012, Madhya Pradesh was the first state, and then many other states and union territories went about banning not only gutka but extended it to smokeless tobacco products. So we are very, very grateful to both the civil society, government, FSSAI, Ministry of Health for having realized how important it was to be able to prohibit availability of such products. Similarly, as soon as there was this entry of new emerging tobacco products in the Indian market and youth were getting attracted to it, the government took a stand against e-cigarettes, and particularly they worked on bringing about initially an ordinance. It was an advisory in August 2018, following which 18 states and union territories notified and implemented the ban, declaring nicotine as an unapproved drug under the existing Drugs and Cosmetics Act, and a poisonous substance under the Poisons Act. And then subsequently, after this advisory, an ordinance was passed, and then a bill was introduced in both the lower and the upper house of our parliament. And this became an act with presidential assent towards the end of 2019. So the basis for banning e-cigarettes was that the government wanted to protect the youth from it starting to initiate this new product, and to protect women in the reproductive age group. Also, India has a very vibrant national tobacco control program, apart from various policy measures, which are our Cigarettes and Other Tobacco Product Act. And under that program, there have been integration with other national programs as well. So under the Integrated Health System Tobacco Control Program has made rapid progress by tying up with TB control, with the NCD's program, oral health program, and these do provide the opportunities to integrate health promotion and preventive measures to be taken under various other programs which support tobacco control. Under industry interference, we have very interesting progress. We don't have a national policy or guidelines on Article 5.3 of FCTC, but various states have progressed to make notifications on their subnational level policies and guidelines on Article 5.3. But with the help of TCCP grant, we were actually able to make the first score on tobacco industry interference index. Way back in 2018, we were able to calculate this for the first time. And with this, this became a regular trend. So Hriday led the 2018 and the 2019 India scoring in partnership with other civil society organizations and the tobacco control experts, because the scoring was done as a consensus among these members, tobacco control experts. They studied frequency and severity of the tobacco industry interference, and based on the government's response to curtail those interference, this score was calculated. And higher the score means more the industry interference. So we very clearly see that with monitoring and evaluation of these kinds, the score has started declining. So from 2018 to 2020, we see there is a gradual decline. And the 2020 scoring was done by IPH in Bangalore, who was part of, right from the first scoring, they were part of this exercise. Our story for pictorial health warning is also very interesting. We started with very weak warnings with 45% on one side of the warning, which made no sense, to warnings 85% on both sides with very effective field-tested warnings. This transition was a long history of court battles, as well as lot of community mobilization and lot of work by the civil society in ensuring that India gets pictorial health warning. So this is now a best practice, because our GATS data is actually showing that many of the cigarette smokers, about 62% current cigarette smokers, about 54% current bidi smokers, and 46% of the current smokeless tobacco users thought about quitting because of this warning label. So this is a very effective intervention, as it is motivating people to quit for which it was intended. Moving further on, we did evaluation of Bollywood movies, which are very, very popular in India. because we have Section 5 of our COTPA, which prohibits all kinds of advertising. But as soon as that rules were implemented, the industry started advertising through movies. And all of a sudden, there was an increase in smoking exposure in movies. We looked at 59 such movies during 2006 to 2008. And this very clearly showed an association between increased exposure and the likelihood that those who were more exposed to these movie exposures were more likely to be at risk of being avid tobacco users. So the risk was double as compared to those in the lowest exposure. And there was a dose-response relationship. So some of these studies led to bringing about rules to curb this exposure. And India is the only global leader in the world to have such stringent regulations for showing tobacco exposure on screen. So there have to be anti-tobacco health spots, there has to be editorial justification, there have to be anti-tobacco health warnings with a static message at the bottom of the screen. There cannot be display of any brands, close-ups, etc. And some of the upcoming literature which is published is actually showing that this exposure actually is going down. So a recent paper published showed that the exposure is 48% currently as compared to what it was in 2005 when it was about 90%. So there are more evidence coming from our research group, which actually is pointing in that direction, that these are effective measures. However, industry keeps evolving. So we were able to curb exposure in movies. And as the youth moved from movies and television to streaming platforms, the industry is completely violating all Section 5 rules in streaming any of the movies or series. None of them are following Section 5 guidelines. So this is a gap we need to plug. Another initiative which has been found to be very effective and is part of our National Tobacco Control Program are the school health programs. Our group randomized trial had very clearly shown that 2 years of intervention can actually bring down tobacco use. When we looked at a group randomized trial, so the current tobacco use actually increased by 68% in control groups where we did not give intervention. And there was a 17% decline in the intervention group. So that was presented, and when the evidence was given at various platforms to the government, to the civil society, this became an important component of our National Tobacco Control Program. Also, India hosted the first international conference on tobacco endgame in 2013. And for tobacco-free future generations, a campaign called No More Tobacco in the 21st Century was launched by youth who were mobilized by Hriday. And this became a global campaign with the next World Conference on Tobacco or Health in 2015. It was taken up as a huge international campaign and continues to get endorsements from very important celebrities and public health leaders globally. To conclude, I would just say that we still need to work on increasing taxation around tobacco products because of heterogeneity across the types of products we have in India. So there is huge scope to increase taxes still on cigarettes, bidis, smokeless tobacco products, and the like. Also, regulation of tobacco imagery on streaming platforms, as I presented. We need to step up our cessation services, and we need impact assessments of these. We have quit lines, we do have end cessation services, but we need what is the impact assessment and effectiveness of these interventions. Our Cigarettes and Other Tobacco Product Act needs some amendments to address some implementation challenges which we have identified over the years. We also need a multi-stakeholder engagement to adopt the vision of tobacco endgame for the country. We do not have it yet, but if we have a target for it, we would know what timelines to look at to achieve that target. And tobacco-free future generation is very important for a country like India, which has so many adolescents and youth. We need to have a vision for a tobacco-free future generation and engage adolescents and youth in our campaigns. And the last emphasis that I want to always make very important for India is we need more tobacco-related research and funding for the country of our size to be able to make progress in a meaningful way. Thank you so much.
Thank you, Dr. Monica. That's very interesting data with regards to the various implementation strategies for tobacco control in India. We'll come back to you with questions after the next speaker. Yeah. I would like to invite Ms. Kellen Nyamurunga from I'm not sure I spelled that right. Ms. Kellen is from the School of Public Health and Center for Tobacco Control in Uganda. She has been a part of the tobacco control activities in Africa from September 2011 and provides technical advice on monitoring and evaluation, supports to build tobacco control capacity, and mainstreaming the tobacco control into public health and poverty reduction programs. Her research interests vary from tobacco industry interference and its economic impact on the implementation of the SCTC and the behavioral interventions in tobacco use. Over to you, Ms. Kellen, and we are interested to hear your talk.
Thank you, Chair, for hosting us as a team, and also for giving me the opportunity to share the best practices in Uganda. And good afternoon, good morning to colleagues. Somebody's managing the slides, right? Or I should manage them myself. Okay. So I'll start with the burden of disease in terms of tobacco use in Uganda. And I start with a global picture where we all know that tobacco use is one of the leading preventable cause of disease and premature death globally, and it kills half of its users. Of course, Uganda is not unique to that, and we have about 7 million deaths annually due to tobacco use. And the WHO report also projects that by 2030, more than 80% of all tobacco-related deaths will occur in low middle income countries. Of course, Uganda is one of those, and that's a worrying statistic. The WHO also continues to report continues to indicate that in Uganda, NCD is a major risk factor. Tobacco use is a major risk factor to NCDs, and it accounts for 25% of all deaths in Uganda, which is even more worrying for policymakers in Uganda. And we have about 1.3 million adults who use tobacco, according to the GATS 2014. And we have a higher prevalence among the youth, which is 17%. That is all youth aged 13 to 15 years. And that's reported in the GYTS, that's the Global Youth Tobacco Survey of 2011. Next slide. So what is the impact of tobacco use in Uganda? A study that was done to analyze data in the Uganda Cancer Institute alone in 2015 indicated that there were 25% of all lung cancer patients who were previous smokers, both previous and current smokers. 16% of all the oral cancer patients were smokers. 13.7% of stomach cancer patients were smokers, and majorly women. And then 12.6% of throat cancer patients were tobacco users, and that's the 2015 report of records in the Uganda Cancer Institute. We also have the economic impact studied in Uganda. We have the direct and indirect cost of tobacco use in Uganda, which is estimated at $126.48 million. And that study was done in 4 disease units. That's the diabetic unit, the Cancer Institute, the cardio, or what we call the Heart Institute, and the chest clinic. And the government spends $126.48 million to manage patients that in these units who are due to cancer, who are due to tobacco use. We also, the same report shows high numbers of productivity lost among workers who smoke, premature death and disability among smokers, and an increasing or deepening poverty. That is, we have more poor people who smoke in Uganda compared to others, of course, leading to malnutrition and an opportunity cost where they will have to miss either education or, you know, or food due to smoking. Next slide. So why do we see an increased tobacco use in Africa and in Uganda? Specifically, we see this because of increased and aggressive marketing by the tobacco industry, and the COVID-19 lockdown, first lockdown, showed us a clear indication of how the industry is marketing, especially to the youth, through the social media and online platforms. We are also seeing social acceptability for groups that were originally not big smokers or users of tobacco. For instance, the girls who are using shisha and the e-cigarette. And these are actually girls who are in college, high school. So we are seeing a shift in that regard. We are also seeing economic development where we're seeing improved incomes among the youth. When they start to work, they also adopt, especially when you look at the university level youth. So they have a little bit of income on them, and therefore they can afford an e-cigarette. They can pay for a pot of shisha with their colleagues. So we are seeing an increase because of that. We also have, of course, high population growth, a high youth population in Uganda of over 75%. And that is a very big target for the tobacco industry. We're also seeing tobacco control still low on the development agenda in Africa and in Uganda. We find that you have the tobacco control law, but the budget allocated to fund tobacco control activities is very low, or if not, none at all. And most activities are funded by donors, and who dictate, you know, the order of issues or what should be funded, without a lot of input from, you know, the communities or the policymakers, because they have no say. It's not their money, it's donor money. Next slide. So then what has happened? We have the WHO FCTC come in place, and we're going to look at the framework convention, but also the goal. The first presenters gave us a very good input into the FCTC, developed in response to global tobacco epidemic. It was evidence-based, or it's an evidence-based treaty. First international health treaty. It's signed currently by 181 countries. And in Uganda, it became effective in 2005. But what is the goal of this framework? I think is the most important thing: to prevent initiation among the youth and young adults, to promote cessation, which is the focus of this year's World No Tobacco Day celebrations, to eliminate exposure to secondhand smoke, to reduce the adverse health consequences of tobacco by substantially reducing the toxins to which users are exposed through their use of tobacco products, and to expand clean air and non-smoking policies to protect non-smokers and to stop prevention and cessation efforts. Next. So what are the best practices? Having Uganda having ratified the convention in 2005, what has Uganda done? What are the best practices? First of all, at governance level and international level, like I mentioned, Uganda has ratified the WHO FCTC, and this indicates the country's commitment to implementing tobacco control. This has provided the country with the foundation and structure for Uganda to implement tobacco control. And when you look at, in my later slides, you'll see our act is very much a comprehensive act that followed mainly the Framework Convention. It establishes best practices for reducing supply and demand, and we followed some of those best practices for reducing supply and demand. And of course, contains articles for use both at national and at local level. So we've followed some of these to the latter, but of course, some are still challenging because of reasons that are beyond the control of the country. Next. So some of the big steps Uganda has done is that Uganda has ably represented Africa at the COP, that is a conference of parties, and on various technical working groups on key FCTC articles, and they've represented so ably well. And also they've had strong representation from government, academia, and civil society. And this has been reflected in policy implementation. When you look at what is being done here, it's more, from that point of view that many policymakers and academia and civil society have participated, meaningfully at COP. And therefore they've, brought the experience and the knowledge back home and have been able to implement useful and valuable tobacco control programs and activities. So at the next slide, looking at our law, it's one of the strongest comprehensive tobacco control legislation on the African continent, and it laid foundation for many others that have followed from the Ugandan Tobacco Control Act. First of all, it showed a lot of political commitment and strong support from government. The president himself, the day he was supposed to look at the act, Philip Morris's team was here, and he told them, no, I will still sign that bill into law. So just give me any other reason why Uganda should continue to grow and export tobacco. So it showed a strong political commitment and government support. In that act, we have also a graphic health warning or pictorial health warning of not less than 65. And currently we've, I think early this year, we have implemented the graphic health warnings where we have 65% both sides, front and the back. The law has 100% smoke-free. It's one of those few laws that provides for 100% smoke-free environment, and smoking within 5 meters of every public place. So it means you can't smoke anywhere because every 5 meters is actually a public place. Then the law also provides for a tobacco control committee. So it's legalized, and that is already in place. And it is headed or spearheaded by the Prime Minister's office, which is a very strong bit of article in the law. Then it offers a total ban on advertising, promotion, and sponsorship, including flavored, including the e-cigarette, and then also offers a ban on the sale of tobacco products to anyone under 21 years of age. Next slide. A continuation with the best practices in tobacco control in Uganda regarding administration, coordination, and management, and specifically looking at Article 5, which includes the 5.3 and all those that go with it, coordination. We have a functional tobacco control coordination, and this is into two. We have the coordination forum, which is brings together all those institutions, civil society, and academia that implements tobacco control on a day-to-day, which is very strong. It was formulated in 2013 and it's led by Ministry of Health. So it's a very strong forum. It's active, there's a WhatsApp group, there's a Facebook page, there's a lot of work that is being done by this forum to coordinate tobacco control on a day-to-day basis. Then we have the National Tobacco Control Coordination Committee, which is chaired by the Office of the Prime Minister, and that was formed in 2018. That's also functional, but its functionality is not yet up and, and to that level that you would want. There's still a lot to be done. And some of the reasons is because of lack of financing. Other reasons are capacity of the members themselves. And of course, the other reason is industry interference. Then in terms of administration, coordination, and management, we also have establishment of a national tobacco control program focusing on policy implementation for the key tobacco control articles 5, 8, 11, 13, and 20. And this was launched last year, and it's again in line with the recommendations of the last COP that we had. Then we have a vibrant civil society fraternity, constant monitoring of the industry, and support to government tobacco control programs. We have one of the strongest, strong civil society fraternity or team in Uganda. And these have done a lot of complementary work to government efforts. They've monitored, and also they've been able to point out on weak areas. They've been able to curb the industry to the extent that they actually led the court case against BAT Uganda. They've also done good implementation at subnational level. Maybe we are the first African country to do subnational tobacco control programs at the district level. So they've done so well in terms of advocacy, awareness, and capacity building for the district level policymakers. They've also been able to attract more funding for tobacco control because we have literally no funding from government towards tobacco control, but civil society have been able to attract more funding for tobacco control in the country. And that has pushed a lot of tobacco control programs forward. Next slide. So in terms of policy implementation on several articles of the WHO FCTC, smoke-free, what Uganda has done, we've had a regulation on Article 8, and that is in place. They've trained enforcers, a number of enforcers. Even just yesterday was following on the WhatsApp group, they arrested a number of bars and pubs that were selling shisha. Shisha is totally banned in Uganda, but we still have, the people who violate the bars and pubs that are violating the law. And yesterday, pre-World No Tobacco Day Eve, they did a lot of good work. And then all public places, including cars and homes, are smoke-free. Of course, that is, I'm careful saying that because we still have pockets, like I'm saying yesterday, there were arrests. We still have pockets of those violators, but we have most of the public places in Uganda smoke-free. Then on pictorial health warnings, we have instituted the graphic health warnings of 65%, both the front and the back. And then on taps, we have a total ban on advertising, promotion, and sponsorship. We still have pockets of violation, but this is one of the articles that is well implemented. We have no adverts, we have no promotion and sponsorship. We've gone ahead, like civil society, to train and create awareness even among government departments and policymakers to alert them not to accept like sponsorships, because in some pockets you hear they're trying to woo a health facility to build them a cancer institute and so on. But civil society has gone in very handy to stop that kind of sponsorships that come coverted to unsuspecting government officials. Next. Next. I lost the group.
Ma'am, we are facing, oh, sorry.
Okay.
It's...
Okay, continuation on policy implementation. We have Article 20, which is tobacco control research and surveillance. And this is where the tobacco control capacity project under the leadership of Linda falls. Let's go back a bit. Previous slide, please. Previous slide, please.
Ma'am, we are facing certain network issues. We'll try to get the
Okay.
previous slide.
Okay. Okay, so under surveillance, Uganda has got and has had an opportunity to do 2 rounds of GATS and 3 rounds of GYTS. And we've also done the NCD step survey, which are recent data sets that we are using. And those have been able to guide policy implementation, but also to guide the implementers to know where they stand in terms of the impact of their programs. But more specific to today also is the tobacco control capacity building project, which is led by Linda. And that picture on the side is when we launched that program in Uganda, and we can see some of the colleagues in that picture. We launched that program in Uganda. We have a fellow, and the fellow is doing 2 huge projects. One is on Article 5.3 implementation, and the other is on smokeless tobacco. But Uganda has also received support in terms of building research capacity. One of them is the IDRC Master's Program that funded 18 master's students to do tobacco-related research. And we had over 25 papers published from that program. We've also had 2 programs, one which is looking at integration of tobacco into TB and HIV. The TB was funded by NIH, and that is being concluded. We should be publishing papers soon out of that. And it has opened eyes of policymakers on how to do integration of tobacco into existing public health programs like TB. We've also got a grant from York University to do HIV tobacco integration. And out of that, we've published 3 papers, and we've had scale-up programs on research activities out of that research. Next slide. So still under implementation, Article 5.3, specific to tobacco industry monitoring, Uganda has been a best practice really under 5.3. We've done a lot of work, including that Constitutional Court of Uganda upholding the act against, of course, and rejecting the tobacco industry challenge, BAT. And that was a landmark victory for tobacco control in Uganda. But we've also had tobacco monitoring teams trained, and they've been very active. So we've been able to identify a lot of industry interference, and that has supported, protected the tobacco control policies from interference. So there's capacity that has been built, but also we've been able to have continued industry monitoring, which is not like piecemeal or not a one-off, but it has been continuous. Then under Article 12, which is awareness, we've had pockets of activities, but one major one that stood out was the mass media health communication intervention, which was a campaign on smoke-free Kampala, as we see the picture on the side, and that generated a lot of support, but also it moved, you know, the country to the next level in terms of creating awareness. And you find that the youth joined, and we still have those social media platforms active, and people now even doing what we call community reporting of those who are violating the smoke-free laws. But one challenge we had is that we got overwhelming a community response. One of them was related to today's, theme, which is quitting or cessation. We had so many people asking us for cessation programs, and we didn't have any. So that was one of the what can I call it, lesson learned out of the mass media. So people got aware and they said, okay, I do smoke, but I would want to quit. Where should I go? And we had not prepared for that. So, and we don't have national programs. We don't have a quit line. We don't have, clearly demarcated program on cessation, or clearly demarcated health facilities that offer cessation. Next slide. So what are the existing policy gaps? One of them is looking at today's focus of the World No Tobacco Day cessation services. Only 4 in 10 current smokers who visit a health facility care provider are actually advised to quit smoking tobacco, which is very low, but also shows a bigger problem. That's according to GATS 2014. And we don't have a quit line. We've not built that much capacity. We have just pockets of training on cessation. We have no guideline. We collect the data, but it's not analyzed, it's not used. We have no community component on cessation. So that's the gap we have, and we need to really work towards bettering the cessation policy implementation in Uganda. We have also still low implementation of Article 5.3, which has been an issue. We have no guidelines. We have not coordinated the sectors to understand 5.3. Even the awareness is still low. There's a mix between Article 5.3 implementation and the tobacco industry monitoring. One of the good studies we've done on the TCCP project is this implementation of Article 5.3, and results are showing us low implementation, low awareness, and there's a mix. And of course, the other one is that we are seeing prioritizing. They are prioritizing other sectors and other areas over and above tobacco control. So we also still have 62.3% of adults who go to bars still exposed to tobacco smoke, and that's still a huge problem in Uganda. We have no taxation policy.
Ms. Kellen, can you wind up in another 1 minute, please?
Yes, this is the last slide. So second last slide. So taxation is still a problem, and of course, lack of policy framework for illicit trade. Last slide. So what are the issues we need to be looking at in terms of bettering policy implementation? We have to be cognizant of the increasing population, increasing incomes among the youth, new tobacco products on the market, that's the e-cigarette, slow and low implementation of the policy framework, the Empower. Capacity is still weak. We have low research index on tobacco control in Uganda and generally in Africa. And then we have low or no government financing for financing towards tobacco control programs. Thank you so much.
Thank you, Ms. Kellen, for that very, a lot of information in your slides. And I thought it was a very proactive measure to protect, to bring down the tobacco menace in your country. But how feasible has it been to, I think I'll start the questions with you. I have a couple of questions for, each of the speakers. So probably we'll start with you. How feasible has it been to implement these very stringent policy, I thought, 100%, smoke-free environment, etc. So how feasible has it been to implement these within the system?
Is that to me?
Yes, please.
Okay. First of all, before we enacted the Comprehensive Tobacco Control Act, we already had what we call the NEMA law. It was a smoke-free directive by government. So the government had already started implementing smoke-free environments, but the nature of implementation was weak. So when the new act came, it repealed that National Environmental Act, which was on smoke-free. So that there was already work that had started. So it propelled, implementing the smoke-free. And of course, we also have a strong civil society. They've taken on awareness and advocacy for smoke-free environments to ensure that the act is implemented, and that has strengthened the implementation.
Thank you so much. And I wish you the very best in continuing your fight against the tobacco menace. So I'll go on to the next speaker. Dr. Monica, I think there are a couple of questions for you.
Yeah.
So we do see that the Indian government seems to be very committed in implementing the tobacco control policies. Do you have any specific suggestion for the district administration in implementing the FCTC strategies?
So under the National Tobacco Control Program, district administration has very clear guidelines given where they already have district tobacco control cell, which is responsible for overall planning, implementation and monitoring of different activities and achievements of both the physical and financial targets which are planned under the program in the district. However, it would be very, very helpful if the district administration also starts at looking at monitoring the progress that they are making and introducing some research, because this impact assessment is so very important and something that we lack in our country. If civil society can be engaged in doing evaluations of these interventions, it is going to be very, very beneficial. It will be learning exercises for other districts who may want to, emulate and replicate the models. And we will be able to evaluate best practices from our local context. So I feel if district administration starts looking at, there are many innovations they are undertaking, which only get shared in workshops that happen. They do workshops, one-day workshops with about 100 participants to build the capacity of multiple stakeholders. But if they also start sharing what innovations they have undertaken and how those innovations have actually benefited and brought about an impact or a change, that will be something which will help not only the district but state, and even at the national level we will have important lessons which we can replicate and maybe scale up in other districts of the country.
Thank you, Dr. Monica. It's very informative and very useful. So hopefully we'll be able to take this fight even in a better, larger scale. Thank you. May I now request Dr. Aarti to just, I think there's one question for you. Yeah, you talked about the smoke-free strategy, bringing down the, overall air quality. Was that indoor or outdoor air quality that you were referring to?
Sorry, yes. So we did the air quality monitoring in the hospitality venue. So those figures that I was quoting were indoor, the air quality of the indoors. Yeah, but we compare that with the outdoor to be able to make a conclusion that it was really the smoke particles that were really responsible for the poor air quality indoors.
Okay. Did you find that the pictorial health warnings that you have, implemented, did it really bring about a change in the tobacco consumption pattern in your region? Or do you have any data with regards to that?
That's a big challenge because we don't really have much data, because tobacco research is not really such a big priority for the government. But we hope that with TCCP and what we've learned from TCCP, we'll be able to move that forward and do more research around. That's one area we really need to look at.
Thank you so much.
Thank you.
Thank you to all the three speakers. It's very informative and gave you as an insight into the work that's going on across continents. So thank you once again. And over to Nikita to take this forward. Yeah.
Thank you, ma'am. Thank you for conducting this session so well. And I thank all the three speakers for their presentation as well as answering the questions. Thank you so much. We will now display the remaining posters of the e-poster competition. Those were truly some amazing posters. All the 134 participants have done a wonderful job and they've given our three judges a very tough time to decide the three best posters. Before I announce the results of this e-poster competition, I would like to introduce our judges. We had Dr. Shobha Kamath, the Associate Professor from Department of Biochemistry, Kasturba Medical College, Manipal, and the Chairperson of the Cultural Coordination Committee, MAHE. Dr. K. Sridhar Ranganathapai, Professor and Head of the Department of Pharmacology, Manipal College of Pharmaceutical Sciences, and Dr. Samit Dash, Senior Grade Lecturer at the Department of Biochemistry, Melika Manipal Medical College, and the Secretary of Cultural Coordination Committee, MAHE. I take this opportunity to thank all of them for their time and effort. This task could not have been easy, but we do have the list of the 3 best posters. And the results are this. Third place goes to Abhishek Goyal from Kasturba Medical College, Manipal. Congratulations, Abhishek. That was a wonderful poster. The second place is backed by Aditya from Maulana Azad Institute of Dental Sciences, Delhi. Congratulations, Aditya. And the first place goes to Dr. Prerna from Prasanna School of Public Health, Manipal. Congratulations to all the winners. Your posters have truly been very thought-provoking. Moving on to the third and the final session. This session on COVID-19 and tobacco and Quit Tobacco Now will be chaired by Dr. Ram Prasad, Professor and Head of the Department of Public Health Dentistry, Manipal College of Dental Sciences. Over to you, sir.
Thank you so much, Nikita. Yes. Warm greetings and a very good afternoon and good evening to all of you. Very interesting inputs and discussions are happening over the sessions planned today. This last session of the day, I'm delighted to introduce our distinguished Associate Professor, Department of Community Medicine, Kasturba Medical College, Manipal, Dr. Muralidhar M. Kulkarni, as well as Dr. Samir Praharaj, Professor and Head, Department of Psychiatry, KMC Manipal, who are the 2 main speakers for this particular session. Dr. Muralidhar Kulkarni is an MD in Community Medicine and has completed the FIMER Interprofessional Education Fellowship in the year 2018 and was awarded the Best Interprofessional Project. He has been involved in research grants being funded by various national and international agencies that include ICMR, Government of Karnataka, PATH USA, Medical Research Council UK, UK Research and Innovation, NIPPCD, New Delhi, and many others. Currently, he is the project lead at Manipal for the MRC UK funded project titled Preventing Smoking Uptake Among Adolescents and the country PI for the GCRF Tobacco Control Capacity Program. He has published research papers in reputed national and international journals and invited to be the academic editor for the +1 journal as well. He has been the Joint Secretary for the Karnataka Association of Community Health and co-chair for the GACD Lung Disease Program from the year 2017 and 19. His research interests include epidemiology of non-communicable diseases and substance use disorders. And above all, a very warm colleague and a true seeker of knowledge. Ladies and gentlemen, a real pleasure to introduce Dr. Muralidhar M. Kulkarni. I hand over the mic to you, sir.
We are now discussing on COVID-19 and tobacco. And in this catastrophic event of COVID-19 pandemic, which has shaken the entire world, I think no webinar will be complete without emphasizing on COVID-19. And we are observing World No Tobacco Day today. And it makes all the more sense to see what is the association between the COVID-19 and tobacco. So this is the scenario of COVID pandemic in India. So currently the country is emerging out of the second wave of the COVID-19 pandemic. We see that around 2 lakh new cases were happening till recently, and which is dipping down gradually. Coming on to the absolute number, the reported cases include 27.2 million, and out of which 24.4 million have recovered, and unfortunately 0.3 million have died due to COVID-19 complications. Coming on to the tobacco use scenario in India, this has been told by the speakers earlier as well. I'm just going to quickly emphasize here that 28.6% of the country's population is using some kind of tobacco product. So the smokers include 10.7% and smokeless tobacco users are 21.4%. Coming on to the absolute numbers, any tobacco users is around 266.8 million. Now let us see the risk factors of severe COVID-19 infection among people. So I have not mentioned all the risk factors here. The key risk factors include heart disease, obesity, diabetes, respiratory conditions like asthma or chronic obstructive pulmonary disease, cancers, and among relatively higher age groups and male gender are likely to face severe COVID-19 infection. Among these, if you see the diseases which are associated with COVID-19 severity, we see here that tobacco use is one of the key factors leading to most of these NCDs. But surprisingly, findings from initial research show that there is inverse relationship between smoking and severe acute respiratory infection due to COVID-19. Now, these kind of conclusions led to a social media hype when the WhatsApp, Facebook, and other social media platforms, this was circulated, which led to confusion among scientists and also to some extent in the medical community as well. Some of my friends did ask me what is happening, whether COVID-19 risk is reduced among smokers. So that was a very difficult question at that point of time. But then when we ponder through the literature, we will come to know the facts and myths which are associated with these kind of misinterpretations. If you see, imagine about a tobacco user, no? They tend to frequently touch their mouth with their hands. So the frequent hand to mouth contact is always there. That definitely increases the risk of transmission of virus. Besides, smokers are likely to have reduced lung capacity. This has been proven since ages. And as has been told earlier also, SLT users are likely to spit indiscriminately, which is again likely to increase the risk of transmission of virus. These are the general aspects with respect to what happens in a tobacco user. Now, if you go back pre-COVID era, what was the stand about smoking and other infections? Smoking has always been known to increase the risk of infection of both bacterial as well as viral diseases. Examples include common cold, influenza, and tuberculosis. The Middle East respiratory syndrome virus, which was there a few years ago earlier, and it was led to outbreaks in some parts of the world. Even there, smoking was proven to be a putative risk factor. Now, suddenly, when it came to COVID-19, is it possible that COVID-19 is an exception to this rule? Yes. So let us see the probable reasons for this misinterpretation. Earlier studies, which I quoted, a few of them which led to the circulation in the social media, it was mainly preliminary observational studies. And smoking was not the primary exposure in these studies, and smokers were underreported in the study, and it was done in few countries only. Coming on to the recent findings, I would like to quote an article which is published in Journal of American Medical Association titled Association of Smoking and Cumulative Pack Year Exposure with COVID-19 Outcomes in a Cleveland Clinic COVID-19 Registry. Here, the pack years exposure was used, unlike in the preliminary studies wherein participants were classified as ever smokers and never smokers. No, they didn't go to the details of pack years exposure. The findings, what is given in the study is that cumulative exposure to cigarette smoke is an independent risk factor for hospital admission and death due to COVID-19. So this draws the curtain on this as doubtful aspect, wherein we come to know that COVID-19 no more protects people. Definitely it harms people, especially those who are using tobacco products. Besides, living rapid evidence review which is being conducted by colleagues from the UK, has shown that the association of smoking status with SARS-CoV-2 infection, hospitalization, and mortality from COVID-19. Here, it is shown that growing evidence that smokers have worse outcomes once infected. Further, the study also warrants that further research is required in this particular area. Now, coming on to our own experience, which was done at Manipal, we did a small study on generating evidence to support policy and practice to address tobacco use during and beyond the COVID-19 pandemic. So this was done by the team at Manipal with technical inputs by the TCCP. Please note that this study was not done among tobacco users or COVID patients. It was done among key stakeholders in the country, in our country. We approached around 72 stakeholders, and they included members from research field, academia, health professionals, government officials, civil society members, private sectors, and others. Besides, we also had good representation from members at the district level, state level, and the national level also. It was glad to know that tobacco use and COVID-19 has been discussed in policy contexts across the media. So 81.8% of them said that this has been actively discussed in the country, which is a good sign. And when we asked about the policy priorities which we should focus during this time, so majority of them, they said that we should be considering raising the taxes on tobacco products, education and awareness about the harms of tobacco, production control, raising fines on tobacco use in public places, policy implementation targeting SLT and hookah usage. The recommendations which came out from the study which was done by our team is to leverage the COVID-19 response to push for reductions in tobacco use and promote tobacco cessation. Widespread propagation of information regarding adverse effects of tobacco and its impact on COVID-19. It's also recommended to form a COVID-19 and tobacco task force for further research, sensitization regarding the tobacco industry interference, and special care for NCD patients during the pandemic as they are more at risk of severe COVID infection. Now we have seen what the preliminary studies which was misinterpreted, and further quality studies which have been done and which have been published recently, and the living rapid evidence review, what they're clearly telling about the impact of tobacco use on COVID-19. Keeping these studies in mind, international as well as local studies, what needs to be done in this context? First of all, it is required that we need to ask patients about their tobacco use status during consultations. This can be done by all healthcare providers, not necessarily one specialty. Irrespective of specialty, every healthcare provider can ask about this tobacco use status and then advise accordingly. Inform such people about the dangers of its use and advise them to quit the habit. Subsequently, those who are willing and people can be motivated to quit, and they could be offered cessation support, telephone quit lines numbers which are there, which is running toll free, it's free of cost, and also recommend about the e-health intervention. Not necessarily this has to be done by doctors. As responsible citizens, as responsible members of the society, each and every one of us can advocate this to our family members, to our friends, to quit tobacco at this juncture. Actively bring up the subject of tobacco use and COVID-19 in consultations with young adults and advise non-users to never start this habit. No, it's rightly said, be smart and don't start. So especially it applies to tobacco use. Health promotion measures, including awareness on tobacco harms, can be imparted at COVID vaccination sites. This is one of the new thing which has started in some of the states, wherein as in the current scenario, everyone is rushing to the COVID vaccination sites. So that could be used as a good point to educate people, to promote or impart health promotion measures, and also advise them about the tobacco harms. And this new approach can be explored further. So these are my references, and I would like to conclude my presentation here with these two information material which has been released by the Ministry of Health and Family Welfare in order to create awareness about preventing tobacco use among the masses in the COVID-19 pandemic. Thank you, one and all.
Thank you so much, Dr. Murli. It was really informative. A real pleasure to know the insights and in-depth knowledge in relation to COVID and tobacco-related issues and the protocols to be followed. Really informative. Thank you so much. I think we'll move on to the second speaker, and after the conclusion of the second speaker, only then we'll be able to take the questions. All right. Thank you so much, Dr. Murli. Thank you so much. I would now invite Dr. Sameer Kumar Praharaj, who's the professor and head of the Department of Psychiatry in KMC Manipal. A real pleasure to introduce him. MBBS from Guwahati Medical College, Guwahati, DPM MD from the Central Institute of Psychiatry in Ranchi, currently professor and head Department of Psychiatry and coordinator of the Clinical Research Center for Neuromodulation in Psychiatry at KMC Manipal, GSMC Finer Fellow in the year 2017 and the DBT India Alliance Fellow of 2020. Interest areas are psychopharmacology, addiction medicine, non-invasive brain stimulation, and medical education. He is the chief associate editor of the Indian Journal of Psychological Medicine and has had numerous publications in peer-reviewed journals and book chapters. He has been conferred upon many awards: the Best Resident Award of the CIP Ranchi in 2007, Samuel Gershon Young Investigator Award, the ISBD Award in 2008, Travel Award for the Early Career Psychiatrist, Professor Raghuram Distinguished Young Teacher Award of the IPS-KC in 2016. Known for his dedication and meticulous preparation, ladies and gentlemen, Dr. Sameer Kumar Praharaj. Thank you, sir. Over to you.
Good evening, everyone. Thank you, Dr. Ram Prasad, for that introduction. I'll start with sharing my presentation. Okay, so yeah, we can move on to the next slide. Yes, so before I start, some facts. So essentially, if you see, so like I said, I'll bring the individual perspective, the clinician perspective in tobacco cessation. So if you see, many of the smokers, so and this has been seen in many of the surveys that they want to quit, and many do attempt on their own. And if you just discuss with people, so at some point of time, people feel that, okay, it's better to quit because of the health benefits. So almost 3/4 of the smokers, they actually want to quit at some point of time. Many do attempt on their own, and you'll be surprised to see that it takes around 30 attempts on an average for a smoker to actually quit. So it's not that with first attempt or second attempt, they're able to quit. So they may stop, they restart. So the cycle continues. And if you see, if they are taking any sort of medical support, medical help, they are much, much more likely to quit as compared to quitting on their own. And we all know about the benefits of quitting. I mean, starting from 20 minutes after quitting, you see the health benefits, and it continues over weeks, over days, over months and years. So we can move to the next slide. So what we need to know is, yeah, so addiction basically is a disease. So that is something we need to understand. We always think that, let's say, smoking or use of any other drugs for that matter, it's more like a habit. I mean, people develop this habit. So I would like to emphasize the other way around. So some people, they use it once in a while, but then at some point of time, they move from just use to, let's say, harmful use or what we call abuse to a more severe kind of condition, which what we call dependence or addiction. So addiction is a disease. It's a chronic disease like any other disease like diabetes, hypertension. So if we have this disease model in mind, we'll be able to help more people. And like I said, some people can quit without any help. So yeah, next. So, but we need to also understand that many more can quit with help. Maybe you can put down all the points so that it will be easy, because I am not able to, yeah, sorry. So many people will be able to quit with help, and it can be any kind of help. So we have a lot of evidence-based strategies which are there, which includes medications, which includes other behavioral interventions, counseling, all these methods which are there, including even brain stimulation, which is now recommended by FDA for smoking cessation. But I'll tell you, if you go by the evidence, even simple advice is much, much more effective than not intervening. So that is where all the role of all the health professionals come into place. So whichever place anyone is working at whatever level, they can identify and give a simple advice, simple health advice, which is much, much better than doing nothing. So to summarize, I should say interventions are there and interventions work, and they work much better than not giving any intervention. Yeah, we can go to the next one. Now, there are many different models of smoking cessation. So one of the most common model that we talk about is a brief intervention model, or to make it complete, we would say SBIRT model, that is screening, brief intervention, and referral for treatment. And there are some simple ways to remember this, how these brief interventions work. One is 5 A's and 5 R's. So 5 A's basically are ask, advise, assess, assist, arrange. So asking is one of the most important thing. I think Dr. Kulkarni also said the same thing. Whichever place you are working, you should always ask the persons whether they use any form of tobacco, be it a smoking form or smokeless form. Another most important thing is asking in a non-judgmental way. So many times we ask, but then the kind of responses that we elicit gets changed, because we are judgmental when we speak, when we ask. Even the way you ask, the tone, the manner in which you speak, the context in which you speak, it can be judgmental. So that is something we need to understand. So when you are asking about, ask more like a matter of fact. No, I mean, people do smoke, people do use tobacco. So just ask as a matter of fact. Okay, so do you use any tobacco products? So that is very important. So that will elicit tobacco usage. The second thing, if once you identify that someone is actually using tobacco, you can do a proper assessment and then see whether it is in dependence pattern or maybe occasional use. Once you do that, you can use a Fagerstrom instrument to quantify whether someone is smoking heavily or once in a while. Once you do that, you should give a very clear advice to quit. And one of the most important thing is because when they are coming to you for any health condition, you should always link to that particular health condition, and you should give a very clear personalized message, advice to quit, and the advice should be very firm and very sincere. So that actually works. So the timing and the way you give that advice is very important, and it has to be a personalized advice rather than saying, okay, smoking causes lung cancer, smoking causes this, that, which most of the people know. They are aware about these things, but then they don't take it because it's not a personalized information. Third thing that you need to do is assessing motivation. So whether the person is actually willing to quit or not willing to quit at this point of time. This is actually very important, because that will determine your further course of action. So what exactly, in next slides, I'll basically tell you about that. So if a person is not motivated to quit, we need to think about motivational intervention strategies. The next step would be to assist in actually quitting. So there are many different methods. I'll discuss more. So we can discuss about a quit date, particular date in which they decide to quit. We can discuss about medication. We can discuss about other non-pharmacological interventions, and always arrange a follow-up, because review is very important. Like I said, many people go through this process. They decide to quit, but then again to restart, and it takes several cycles for them to actually understand the actual benefits of quitting and the real need for quitting. So the actual motivation comes after several cycles of treatment. So we should not lose heart, and then we need to be persistent. Yeah, so next slide. Yeah, we need to understand that the people who are planning to quit and are quitting go through several steps. So starting from pre-contemplation, in which they have not decided yet to quit, to contemplation, when they start thinking about quitting, they're ambivalent, but then after that, they take a decision that I want to quit, and then they actually quit, and then they continue in that phase. Or it actually is a cycle, because they can again go back to smoking again, and then the whole cycle starts to again from pre-contemplation to action stage. And this cycle actually continues several times before they actually quit. Yeah, so next slide. Yes, so now if patients are actually willing to quit, so what we can do for them? So when we identify that someone is actually willing to quit, so that is the time when you should be thinking about a very structured counseling. It can be a very brief counseling. It need not be for half an hour, 1 hour duration. It can be just 5 minutes or 10 minutes, but it should be a very structured counseling that may be useful. We should always discuss about a quit date, when exactly they want to quit. So that actually is helpful. And once they decide on the quit date, so we should encourage, and then the person should stick to that. We should also discuss about the different potential triggers. So the people who would be smoking with the slightest of stress, or let's say there are particular routines also, like some people would be smoking immediately after getting up from bed, or maybe during their tea breaks, or post lunch or post dinner. So we'll need to find out those routines and triggers. They may be, let's say, buying their tobacco on their way to work, or in let's say lunch breaks, in the work schedules. So we need to identify those triggers and routines. Even friends, specific friends who give company during smoking. Once we identify that, we need to discuss with them how they are going to manage these kind of triggers and routines. And of course, we need to discuss about what are the strategies they are actually going to do to, let's say, if a friend offers a smoke, how they are going to say no or avoid that particular situation. So these are some of the strategies that need to be discussed during the session, the structured counseling session. And of course, we have a lot of self-help materials which are available, printed materials. Nowadays, you have different apps and e-health materials which can be given to the patients, so that they can go through them, and which can be useful. It can be sort of a reminder to continue with the quit process. And of course, we have different pharmacotherapy and relaxation techniques which can be taught to manage their anxiety, because many people know that during anxious states they tend to smoke more. Yeah, so next slide. So before I tell about the different medications, we should know that actually medications, if you see this graph, no drug versus any drug. So NRT is nicotine replacement therapies, bupropion, varenicline, which are the medications, or the combination. If you see, varenicline and the combination NRT are the most effective ones. So medications actually increase quit rate. It almost doubles or triples the quit rate. So that is something we need to understand. Also, we need to understand that these medications are not very effective. If you see, around 30%, so 1/3 of patients will quit with medications. So, but still, if you see, without drugs, let's say only 1/6 or 1/7 will quit. So in that way, medications actually double the quit rates. So that is something we need to understand. And this information can be shared with the patients. Yeah, next slide. So there are many different nicotine replacement approaches. So we have seen in our practice that among all the formulations that are available, the formulations which have sustained delivery, like let's say patches. Patches actually give a sustained delivery over 24 hours. So you need to just use a patch once in a day. So these are much better as compared to gums. Let's say chewing gums, which the person need to use, let's say several times in a day, and they need to use it in a particular way. If they don't use it in the specified technique, so it is not very effective, and there are fluctuations in the nicotine levels. So that way, patches are definitely much better, and they give good clinical result as well. So this is something we need to keep in mind. Also, we need to understand that these replacement techniques should be used for several weeks. It is not just using for few days that one is able to get over nicotine use. And many will come and say, okay, I still smoke even if I use a patch. So we need to tell them that okay, it's not something which will happen immediately. Take some time. We need to continue it for several weeks. Usually we recommend around 3 months, maybe more depending on the clinical condition, clinical situation. And also many times the dosing is an issue. So many times it doesn't work because we don't use the appropriate doses. So if someone is smoking more heavily, so we need to prescribe higher doses of medications. And education is something which is very important. Just prescribing nicotine is not enough. Nicotine is anyway available over the counter, and many patients say that, okay, I have used it and didn't work. When you ask, you will see that the use was quite faulty. So we need to educate patients. So how it is going to help, and how long they need to continue. So what they are going to do when they're using this. Many patients would actually discontinue this nicotine replacements because of different kind of inconvenience or adverse effects. So specifically with patches, there can be rashes and other problems. So we need to discuss about all these things with the patients. Simple measures, but then that goes a long way. Yeah, next slide. There are many different anti-craving medications. The most common one are varenicline and bupropion. Varenicline is available, but it is quite costly. So many don't accept because of that reason. Bupropion is that way safer, cheaper also. There are some issues that we need to understand when we are giving these anti-craving medications, because you need to know about the medical and psychiatric comorbidities. There are certain conditions in which you have to be careful when you are prescribing these medications. Let's say, for example, bupropion in patients who have psychosis, in which actually the smoking rates are quite high. So almost 80% of patients with psychosis smoke. But then you have to be very careful when you're prescribing bupropion, because that will worsen psychosis. So that's why this medication need to be given under supervision. So it's always better these medications are supervised. And of course, these medications are given for long term, minimum 6 months, maybe longer, sometimes even in years. We'll have to continue these medications. Yeah, so that patients get benefit from these medications. Yeah, next slide. Now, if a patient is not motivated to quit, then what to do? So one thing that we can do is try to find different reason. So why they're not able to quit. So we can use many techniques like motivational interviewing. So this is where a little bit of specialized services help. There are many approaches in which if a patient says, okay, I am not able to stop it altogether, we can think about discussing about some form of harm reduction in which they start reducing the usage, and they may use nicotine replacement along with smoking. There are other approaches, like we can use biofeedback to give a feedback about carbon monoxide levels in exhaled air, or lung gauge, which can be calculated using a spirometer. So this feedback also helps sometimes, so that at least even when they have this information, they from pre-contemplation, they move to contemplation phases, and they think seriously about quitting. And of course, if they are actually resistant, not motivated to quit, that is one indication where we should be referring them to addiction specialists who were trained to use motivational interviewing methods, which will be helpful. In this context, there are 5 R's that we should remember. One is the relevance. So you need to tell about, again, more like a personalized feedback. Tell them why it is important, why quitting is important for them specifically, and what are the risks that are there if they continue quitting, what are the rewards, the benefits of tobacco cessation, what are the roadblocks, what are the problems. So they might have tried on their own sometimes, and they would have given up. So we'll have to identify what are the roadblocks, and every time we need to do the same thing. Okay, so repeat it, so that give the advice. So like I said, people take several cycles to actually understand and actually are able to quit. Yeah, next slide. So the next thing I'll talk about is tobacco cessation clinics. So these are specialized clinics. We don't have too many of tobacco cessation clinics in India as such. These are multidisciplinary clinics and use simple intervention models. I mean, it's not that they'll be using too complicated interventions there. Again, the same brief intervention models, but they will do a lot of other assessments. We can do a holistic assessment, look into the medical condition, because you'll have specialists, let's say from dental side or from respiratory medicine. So they come together and then they assess, and then you use basically use feedback in a more appropriate way. Also, these clinics should create awareness in communities and among other users. Also should generate evidence. And we are actually in the process of developing a tobacco cessation clinic along with dental medicine here. So Dr. Ram Prasad is part of that clinic, although because of COVID, actually it got delayed. So we'll be coming up with a multidisciplinary tobacco cessation clinic in KMC. Yeah, next slide. So to summarize, so again, I'll reiterate. So all persons who come in contact with healthcare, any place, should be routinely asked about tobacco use. So this is the most important step to identify, and they should be encouraged to quit. So at least given a very firm, personalized advice to quit. So these two things, two steps actually will go a long way when we're talking about, let's say, individual level intervention for everyone. So more like a universal kind of intervention. Of course, those are not ready to quit. Motivational interventions may be required and may require some specialized services. Medications are there. So we have, like I said, with help with brief intervention as well as medications. Many patients will be able to quit, and the quit rates are higher, the quit time is less. So we need to raise awareness among public regarding this, and in the end, of course, a timely referral is the key. So when you identify these problems, you should refer them to appropriate places so that they get appropriate treatment available. So yeah, I'll stop here. Next slide. Yeah. So to end, so thank you for this opportunity. So any questions, welcome.
Yeah, thank you so much, Samir. It was really very informative, a very clear presentation where we were able to understand the insights and the depth of the topic, in the sense, what are the issues that actually come up, and how to handle it, and how to deliver better care for the patient. So thank you so much. It was really a very useful session. This particular session, we have had two questions. One question for Dr. Murali and one question for Dr. Samir. First, I would like to ask the question which has been asked for Dr. Murali. Dr. Muralidhar, actually, if the hazards of tobacco are well known, if the hazards of tobacco are already well known and established, and particularly so because of the COVID pandemic, we are already aware of the relationship between the pandemic and tobacco use. Why can't the medical and dental fraternity and faculty come together and pressurize for a ban on tobacco production and sale? So the question is very particular. Why can't all the medical and dental faculty come together, the whole fraternity, the associations come together and pressurize for a total ban on tobacco production and sale? Your viewpoints on this, please. Thanks. A very interesting question, but yeah, to know your viewpoints.
Thank you for this question. And Dr. Ram, to tell you frankly, wherever we go for conducting FGDs or in-depth interviews for tobacco vendors or schools, this is a very common question. We have been hearing this question since 3 to 4 years now. why don't you ban it? Why are you struggling so much, and why don't you ban it? Yes, Dr. Monica mentioned in her talk, and Dr. Linda also mentioned about steps taken by New Zealand government on tobacco endgame. And as Dr. Monica mentioned, we have taken small steps towards that. One among them is banning gutka. Madhya Pradesh, I think, was the first state in our country to ban gutka. Later on, Karnataka also followed the footsteps. Yes, it is not enough. Still we have to go a long way. And and fortunately, Government of India has banned e-cigarettes. That is one more good thing, because youth would get exposed to it, and that one harm is prevented. And with respect to one of the recent discussion with the state level official, I asked him whose responsibility it is for controlling tobacco or preventing tobacco. I still remember that version of her. I would like to quote that only, rather than going by textbooks or anything. She told me that from the remote person in the remotest village in Karnataka, we asked at the state level, to the governor, it is everybody's responsibility. So the person who has asked this question, so it is not one person's responsibility. Everybody should take responsibility for this. It is, in fact, it should be a people's movement, and government is doing its part. The health fraternity is doing its part, but then we are doing our. We request all of you to join, all the audience and the students, to join this movement and help us in achieving this goal. And recently, to be another information I would like to share here is the government of Karnataka is very particular in considering tobacco-free generation policy. In the month of December, there was a state-level consultation, and probably not very later, but then soon we'll be hearing that government of Karnataka will unveil tobacco-free generation. That means people who are born after 2007 should not be sold any tobacco products.
Right.
We have to see it from the other side of the prism as well. 22% of people in our state, 28% across the country are using tobacco products. So,
right.
As Samir has mentioned, it's a very addictive substance. Overnight, we cannot ban it. The prevalence has to gradually come down. Efforts have to be made. Multidisciplinary approach and multi-pronged approaches have to be taken. And gradually, I think we will see the light at the end of the tunnel, that tobacco endgame is not very far. So
definitely. Yeah, thank you so much, Dr. Murli. I think knowledge, research, action, policy, it's a translatory phase, and we are in the process. So we have to be a little more patient. And the WHO has given the theme of NMT 21C. So I think on those lines, no more tobacco 21st century. So 2099 is the total deadline that has been set. So I think we are in the process, and incrementally there is an effort from all countries to eliminate this menace totally. And also the fact that the tobacco control is an issue which has to be taken up rightly, as you said, at all levels. And even in India, we are seeing tobacco-free cities, tobacco-free villages, tobacco-free towns which are coming up. For example, Dhanbad was declared as smoke-free. So there are some cities coming up even in India which are totally becoming tobacco-free. I think we are in the process, and it will take some more time and some more effort to achieve that.
So
yeah, thank you so much.
Tobacco-free homes is one more entity.
Free homes. Yeah, we
So
start
let us
from
make
the
our homes tobacco-free, country will be tobacco-free.
Absolutely, a wonderful response to a wonderful and weighted question. That I could see the weight of the question and a very value-added discussion here. Thank you so much, Dr. Murli. One more question for Dr. Samir. Dr. Samir, what are your views on incorporating cessation services at the primary health level? Primary health center level, what are your views on incorporating cessation services at the primary health center level? Your viewpoints on that, please. Thanks.
Yeah. So at PSC level, it should be same, the model that I said, SBIRT model, which will be very useful. So screening, brief intervention, and referral for treatment. So screening of everyone who comes to PHC using very simple questions, brief intervention by which is not something which needs a lot of training. So there are very specific steps which are given by WHO, which can be, there are very nice manuals, very clearly written guidelines. So maybe 5 minutes you can spend with all patients. So advising about stopping tobacco. And if it doesn't work, that can escalate it to the next level. So
Right.
referral. So I think that is the model that need to be used across PHCs
Right.
to achieve this.
And then the manpower issues also needs to be addressed accordingly. We need to make sure that there is adequate manpower to address this. So that I think those are the issues. All right. Thank you so much, Dr. Samir. I think we have had a very interesting session, COVID pandemic, as well as guidelines in relation to tobacco control from the psychiatric perspective. And we've had a very healthy discussion as well as interesting questions from the audience. So I think we've come to the end of this particular session, and I hand over the mic to Dr. Nikita. Yeah, Ms. Nikita. Thank you so much. Thank you so much, Dr. Murli and Dr. Samir. Thank you so much. Thanks for joining us today. Yeah. Over to Nikita. Thanks a lot. Thanks.
Thank you. Thank you, Dr. Ramprasad, for conducting that session so very well. And I thank both our speakers for such an illuminating presentation, as well as answering those weighted questions, as you said. With this, we have come to the end of our session by our experts. It has indeed been a very illuminating session. All of our 8 speakers have have given us their expertise and have answered all of our queries. I now request Professor Linda Bold to give her closing remarks.
Thank you very much, Chair. I really appreciate that. I'll be brief because I know we've been on the webinar for some time and it's been fascinating. So I just want to say a few words, mostly of thanks. I know we are going to have a vote of thanks, but just to emphasize, this webinar, I think, has reminded all of us that tobacco use and tobacco-related conditions and tobacco-related mortality as an issue hasn't gone away. As we were hearing from several of the speakers, the current focus now, quite understandably, is on infectious disease and COVID-19. But as we emerge from this period, and we will emerge, all countries eventually, I think the job of those of us working in non-communicable disease prevention is to align these 2 agendas and work to try and keep a focus on preventing chronic illness through reducing tobacco use. And that means preventing uptake, as many of you have discussed, in young people, as well as we've just heard from Dr. Samir, absolutely focusing on treating those who are addicted to tobacco. So I just want to pass on my sincere thanks to Dr. Murli, to the Joint Secretary who spoke, to the Vice Chancellor, to the chairs of all the sessions, to the excellent speakers, including my colleagues from the Tobacco Control Capacity Programme. And we hope that we will be able to meet face-to-face again in future. I know we're all desperately missing seeing our colleagues in that way, but I think you've proved again today with some really outstanding technical assistance, actually, that these meetings online can be highly productive. And then the final thing, just to tell you how hugely impressed I was with the posters. What a phenomenal effort from the young adults, colleagues and participants sending those in. They were just fantastic and a wonderful response to see so many of them. So thank you very much, sincere gratitude. Best wishes to you all from Scotland and the UK, and I'll hand over to the final speaker. Thank you.
Thank you. Thank you so much, ma'am. And I second that. I sincerely hope that we will be able to meet face-to-face someday, hopefully sooner rather than later. But nonetheless, for right now, we'll settle. I will settle for this Zoom conversation. Before I call on Dr. Benel for the vote of thanks, let us have a quick photograph. There are still quite a lot of you present here today. Some of you who weren't present for the earlier photograph. I request all of you present at the Zoom platform to please switch on your cameras or turn on your videos. Yes, I request all of, I think, Dr. Ramprasad is here. Dr. Veena Kamath, Ms. Kellen, if you could. Thank you so much. All right, I'll be clicking. Veena ma'am, if you can, if your network bandwidth allows you, if you could. Okay. All right, I will click the photo in 3. All right, we have Dr. Veena as well. Okay, I'll be clicking the photo in 3, 2, 1. Just a minute. All right, just another quick photo in 3, 2, 1. Okay, thank you so much. There's some lovely memories captured through a photograph, and we'll be sending this across as soon as possible. Before, yes, yeah, so today's webinar has taken a lot of efforts from a lot of people, and one particular part of it has been our audience who have all logged in and are present at this webinar. Especially to all the students who have registered. I know it's been a hard time. You have had to listen to online classes throughout the day and including this online webinar right now. So we would like to give all of you an e-certificate. So I request all of you to please fill in the fill in the form. This is a feedback form that's been shared to you. The link has been posted in the YouTube chat box. I request all of you to please fill this feedback form and mention your details correctly, particularly your email ID, because you'll get an e-certificate for participating in this webinar, and it will be sent to your email ID. So please make sure that you mention your details correctly. I hope you've made a note of the QR code, as well as, or if you'd like, you can make a note of the link as well. Okay, thank you, Calvin. Moving on. Today's webinar would not have been a success but for the efforts and cooperation of all those involved. And there have been many people who have worked tirelessly to make this possible. I now request Dr. Binal, the Associate Professor from the Department of Mental Health Nursing at Manipal College of Nursing and the Co-Principal Investigator of the Nashamukt Utpi Abhiyan project, to deliver the vote of thanks. Over to you, sir.
Thank you, Ms. Nikita. Hello, everyone. I feel honored and privileged to have the opportunity to propose the vote of thanks on this special day. First and foremost, I would like to extend my sincere gratitude to our chief guest, Mrs. Radhika Chakravarti, Joint Secretary, Ministry of Social Justice and Empowerment, Government of India, for gracing this occasion and delivering the inaugural address. Thank you, ma'am. I would like to express our profound gratitude to our Honorable Vice Chancellor, Lieutenant General Dr. M.T. Venkatesh, for presiding over this program and for his presidential address. Thank you, sir. I would like to express my heartfelt thanks to Professor Linda Bold, Bruce and John Asher Chair of Public Health, the University of Edinburgh, for her enlightening keynote address and closing remarks. Thank you, Professor Linda. I would like to thank our distinguished speakers, Professor John Britton, Professor Emeritus, University of Nottingham, Mr. A.S.M. Abdullah, ARK Foundation, Bangladesh, Dr. Salama with Addis Ababa University, Ethiopia, Dr. Arti Singh, KNUST, Ghana, Dr. Monica Arora, Executive Director, Hriday, and Professor, Health Promotion Division, Public Health Foundation of India, Ms. Kellen Nyamurugi, Makerere School of Public Health, Uganda, Dr. Muralidhar Kulkarni, Associate Professor, Department of Community Medicine, Kasturba Medical College, Mahe, Manipal, and Dr. Samit Kumar Praharaj, Professor and Head, Department of Psychiatry, Kasturba Medical College, Mahe, Manipal, for making excellent presentations and making this webinar interesting and meaningful. I would like to extend my deep appreciation to our chairpersons, Dr. Veena Kamath, Professor, Department of Community Medicine, Kasturba Medical College, Manipal, Dr. Asha Kamath, Professor and Head, Department of Data Science and Associate Director, Prasanna School of Public Health, Manipal, Dr. Suma Nair, Professor and Head, Department of Community Medicine, Kasturba Medical College, Manipal, and Dr. Ram Prasad VP, Professor and Head, Department of Public Health Dentistry, Manipal College of Dental Sciences, Manipal, for managing each session smoothly. We express our sincere thanks to the Ministry of Social Justice and Empowerment, Government of India, the Medical Research Council of United Kingdom, and the Manipal Academy of Higher Education for encouraging and guiding us in organizing this webinar. We also extend our thanks to Dr. Sijo George, Manager, Mr. Hassan Khan, State Coordinator, Project Monitoring Unit, Ministry of Social Justice and Empowerment, Government of India, and Ms. Ami, Coordinator, Tobacco Control Capacity Program, for helping us to coordinate the event. My sincere thanks to the webinar coordinators, Dr. Geeta Maya, Director, Department of Student Affairs, Mahe, Manipal, and Dr. Muralidhar Kulkarni, Associate Professor, Department of Community Medicine, Kasturba Medical College, Mahe, Manipal, and their team for working hard towards making this webinar a great success. A special word of thanks to Ms. Nikita Meneses, Legal Executive Mahe Manipal for being the Master of Ceremonies for today's program. We acknowledge the efforts of the judges for the e-poster competition, Dr. Shobha U. Kamath, Dr. Sambit Dash, and Dr. K. Sridhara Ranganath Pai. We extend our thanks to Mr. Suresh, Assistant Director, Audiovisual Department, Mahe Manipal, and Mr. Sadish Kamath, Assistant Director, Department of IT, Mahe Manipal, for their support. Finally, our heartfelt thanks to all the students and other participants who made this event a successful one. Thank you all.
Thank you, Dr. Binil, and thank you as well for all the efforts that you've put in to make sure that this event becomes a success. With this, we have come to the end of the international webinar on tobacco control. As I bid you all adieu, I would like to congratulate all those who have managed to get rid of their addiction to tobacco. Thank you sincerely for setting an example to so many others who are trying to do the same. And to those who are still finding their way, remember, a river cuts through rock not because of its power, but because of its persistence. So keep trying and never give up. You will win this battle against your addiction. Stay healthy, stay safe. Have a good weekend. Thank you. Again, we are posting this link for the Google form, the QR code as well as the link. I request all the student participants to please fill the form and you'll receive an e-certificate for your participation in this webinar.